ये मेरे लिए बोल रहे हैं कि आप? हाँ, यस। डॉक्टर आबा, हेलो। डॉक्टर आबा has joined. डॉक्टर आबा सिंह. How is
Namaskar, madam.
hello,
Namaste, ma'am.
Namaste, madam.
Namaste.
Good evening to everybody who has joined.
Namaste, good evening.
Thank you, madam. Thank you for your precious presence.
नहीं, ma'am. Thank you so much for extending your invitation.
Good evening, ma'am.
We look forward always.
Good evening,
Hello,
Manoj.
hello, Manoj. Hello.
Hello, hello.
How are you, ma'am?
नमस्कार.
Good.
नमस्ते सर. हेलो आशा.
नमस्कार. नमस्कार.
नमस्ते मैम, मैंने पहले ही बोला आपको.
हाँ, मैंने भी बोला, सबको बोला. कुछ ही लोग दिख पाते हैं ना इसमें.
मैम उसमें गैलरी व्यू कर दीजिए, सब दिखेंगे.
हाँ ठीक है, कर सकते हैं.
लैपटॉप पे तो दिखते हैं. हेलो डॉक्टर रश्मि. हेलो डॉक्टर मणि. लैपटॉप पे दिखता है अच्छा व्यू, मोबाइल पे समटाइम वी मिस. हेलो डॉक्टर स्नेह प्रभा.
हेलो मैडम, गुड इवनिंग. नमस्कार मैडम.
गुड इवनिंग. गुड इवनिंग.
Hello, Madam Sadhna Gupta. I met you in Banaras.
Yes. Yes. Hello, Smita.
Hello, good evening, madam. Good evening.
Hello, Smita.
Good evening.
Good evening.
Smita,
Dr. Anju, we start sharp at 5.
Yes, madam.
2 minutes we will start, and let me call Dr. Kavita. No? Dr. Mandakini is in, and she will be joining a little late. No? So all set. First speaker Aparna. She is the first speaker, and let us call so that we are ready.
Hello, Dr. Smita.
Hello, Dr. Anju. Hello, Sadhna ma'am.
Hello, Smita. So good to have you.
Thank you, ma'am. Thank you.
So always in legal panels, now what we say, all these things, now this thing and that, this anomaly, and then the legal issues. So hope a panel play the role that we don't get up in the legal issues.
तो स्नेह मैम, आप 2 चीजों से ना लॉग इन करें, नहीं तो आवाज गूंजेगी. आप 2 चीजों से लॉग इन हो गए हैं.
My
से लॉग इन होइए. आवाज.
हेलो आशा मैम, कैसे हैं?
यस मैडम, बिल्कुल बढ़िया. ओके मैडम, हाउ आर यू?
Shall we start now?
Ma'am, when we are ready, tell me, I will start sharing the screen. Anju ma'am.
Yes, sure. Madam, Dr. Kavita Ensing is joining. Dr. Sadhna Gupta is there, na, madam?
Dr. Aparna has joined, Dr. Anju. Hello, Dr. Aparna.
Hello.
Hello, welcome, Aparna.
How are you?
Very good, ma'am. How are you?
We all good. So nice.
Aparna, you can check the slide share.
मैम होगा, मैम हो जाएगा.
You can check your slide share option. So,
Yes, ma'am.
hello.
नमस्कार डॉक्टर रश्मि.
हाँ, डॉक्टर कविता वेट कर रहे हैं आपका बस.
ठीक है
हाँ.
मैम.
Yes,
हाँ,
yes,
हाँ,
perfect.
आ गया, बस आपका वेट कर रही हूँ.
Shall we start, madam?
साधना मैम स्टार्ट करें क्या?
2 मिनट बस. डॉक्टर कविता ज्वाइन कर रहे हैं
Okay,
और अपर्णा ने ज्वाइन लिया. जस्ट इन द मीन टाइम आई विल जस्ट check my slide share. It's visible na? Very quick. Visible slides. My slides are visible.
Yeah, madam, it's
Yes,
visible.
yes.
So fine. अपर्णा आप भी देख लीजिए. डॉक्टर कविता जस्ट ज्वाइन कर रही है. It is 6:03. Yes, we can
मैम
start.
मैंने
So,
देख लिया.
हाँ देख लिया. Then it's fine. So I think we can start. Dr. Abha Singh is with us, so our chief guest. So, Corona people, please make it live and say the countdown.
It's already live, madam.
Okay, okay. Good evening, friends. Welcome to this webinar of E-Classic Clinical Series in association with today with Madhya Pradesh and Chhattisgarh, which is such an initiative to disseminate knowledge and keep the clinician update with the recent information in medical fraternity in each field of obstetrics. And I thank Dr. Sadhana Gupta madam to take a lead and start this novel concept. Madam is a very senior, compassionate, disciplined, dynamic, versatile personality with immense knowledge of her subject, with all best leadership quality. And I welcome Madam Dr. Sadhana Gupta.
So thank you, Anju. And first of all, my heartiest thanks and gratitude for all office bearers of MP and Chhattisgarh Society, Raipur, Dr. Tabassum Dalla, Dr. Monica Pathak, from Bilaspur, Dr. Rashmi Sharma, Dr. Pratibha, from Bhilai, Dr. Sangeeta Sinha, Dr. Kirti Kaura, from Jabalpur, Dr. Manik Pandey, Dr. Dipali, from Hoshangabad, Dr. Shruti Malvi, Dr. Ruchi Saxena, from Sagar, Dr. Jagrati Nagar, Dr. Taruna Sharma, and from Katni, Dr. Vandana Gupta and Dr. Nidhi Vijan. So you stop the slide share for my CV, please. Pranjal, yes. So because actually everybody's initiative and everybody coming forward for all these academic learning and share is the great thing, and I heartily thank you. Thank every society's office bearer for bringing us all together on this very particular platform. So Dr. Anju and Dr. Asha Jain is coordinating and working taking a great effort in making all the sessions and the communication possible. And with this, it is a great pleasure to have none other than Dr. Abha Singh as a chief guest. And we always see Dr. Abha Singh since a long time, a mentor figure in whole of the Madhya Pradesh and Chhattisgarh, and we can see that she remains as young as we used to see her around 30 years ago. So Dr. Abha Singh, so a warm welcome to you, and it is a real great pleasure to introduce Dr. Abha Singh. Please, can I have CV of Dr. Abha Singh? So warm welcome. And Dr. Abha Singh has been the Vice President of the Society of Vaginal Surgeons of India, founder and present President AOGOG, patron ROGS and IFSCG, IMS and Raipur. So Madam has been a key figure for founding the various associations, and she is keeping a great legacy onward. She has been the past president of Raipur Obsgynae Society, Raipur, and IMS Raipur, awarded CM Trophy for Meritorious Service 2002, Padam Shri S.K. Mukherjee Award 2005, Rashtriya Gaurav Award 2009, Best Paper in Oncology 2013, and Health Icon of Chhattisgarh by Times of India in 2016. She has been ex-dean Pandit Jayalan Medical College, Raipur. Generations of students have been privileged to have her as a teacher. Ex-vice chancellor, Deen University of Medical Sciences, ardent academician and the research worker with 110 plus papers, 80 articles, and conducted a lot of live workshops on NDBH, colposcopy, program, labor, uterine ligation, and we have been the part of many her programs and initiatives. And her special field of interest in infertility, medical disorder of pregnancy, minimal invasive and vaginal surgery, and AUB. A warm welcome, Dr. Abha Singh, for gracing the occasion, and we look forward to hear from you for pearls of wisdom.
Thank you very much, Dr. Sadhana Gupta, for making me a part of this very prestigious CME. And I have just loved your theme that every obstetrician is a basic fetal medicine specialist. So I think gone are those days when we used to see in those black and white and blockbuster Hindi movies, when the doctor will come and declare, the obstetrician would come and declare कि माँ या बच्चे में से एक ही को बचा सकते हैं, right? So we have come a long way. So that was the obstetrician in the past, and now I feel that every obstetrician, as you have rightly named the theme, that she or he is a basic fetal medicine specialist, and in every pregnancy, it is the obstetrician who cares for the mother as well as for the fetus. And we have some lovely speakers on different aspects of this specialty. So without wasting much time, I first of all want to thank Dr. Anju for organizing this so well. And Dr. Sadhana Gupta, she is a very knowledgeable, I would say, and very dynamic leader. And she has worked so hard in FOGSI for past so many years. And ma'am, I really wish you all the best for your future tenure. And always my best wishes to you. Thank you so much for inviting me to be the chief guest in today's CME. Thank you so much.
Thank you, Dr. Abha Singh, for your precious word and recollecting past and how we are going to future. And your wishes and blessings are precious for me, and I hope that we will be doing a lot of work together and bringing Chhattisgarh and MP to a bigger platform, and including all experience and expertise at the bigger platform. So thank you very much. Dr. Mandakini Pradhan is she is in some intrauterine transfusion, so she will be joining around at 5:30. Dr. Kavita Singh is with us. Thank you, Dr. Kavita. You have joined. I'm seeing you, Dr. Kavita. Yes. Her videos. So thank you, Dr. Kavita, to grace the event as a guest of honor. And Dr. Kavita Singh has been a very, very close association, and we know her for her ardent work in the prevention of cancers cervix. So let me introduce Dr. Kavita. Can I have CV of Dr. Kavita Singh? Hello. Yes. Dr. Kavita Singh, a very known figure, professor and HOD obstetric and gynecology, NSCP Medical College, Jabalpur, WHO Master Trainer, colposcopy, gynae, oncosurgeon. But she is known for her keen interest in the preventive and the curative oncology, organizing chairperson of many conferences, and just last year we have a West Zone Yuva FOGSI MPOX 2013, Eugene 2013. She has been the past president of Jabalpur Obs Gynae Society, Rotary Club of Jabalpur, State Secretary MPOGS, and more than 15 state and national award, more than 45 index publication, and she has been the guide for many research work, textbook chapters in international scientific monograph, and the passionate teacher more than 23 years. She has been adored by her teachers always. And a warm welcome, Dr. Kavita. Please, Dr. Kavita, and please stop slide share so we can have a yes.
Hello, good evening, Dr. Sadhna Desai, Dr. Abha Singh, Dr.
Sadhna Gupta.
Sadhna
Anu,
Gupta.
and I am so happy to see everyone in the, on the small screen, and it's wonderful that you have connected 7-8 cities together on one platform for a wonderful CME on unborn unsung hero, that is, fetus. And because all the heroes someday were
I think some network error issue is there.
the wonderful speakers in this CME. My best wishes to you, dear madam, for your presidential candidature for coming time. Sometimes I really wonder, there are 4 wonderful ladies contesting for one post. you know, uh, so all the best for you, and my best wishes are with you. Thank you so much for remembering me. Thank you.
Now I would like to invite.
Thank you, Dr. Kavita, for. And
Yes, now I would like to invite all our faculty on a virtual platform for lamp lighting and formal inauguration. Nilesh ji.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Thank you, Nilesh ji. Now, without wasting any time, we will proceed further. And for our first session, keynote address by a very eminent speaker, I would like to invite the chairpersons, Dr. Manik Panse. Nilesh ji, can we have the CV? Dr. Manik Panse is Associate Professor in DMC Ludhiana for 5 years, practicing in basic obs and gynae since more than 30 years, with special interest in high-risk pregnancy and menopausal counseling. She is Director of NABH recognized Anant Multi-Speciality Hospital in Jabalpur, which has completed 23 graceful years. Apart from doing a lot of social work, pursuing she pursued Indian classical vocal music. Welcome, madam.
Thank you.
Dr. Shruti Malvi, who is Director KBPN Malvi Hospital, Narmadapuram, Founder Secretary Hoshangabad Obs and Gynae Society, working in Obs and Gynae in private sector since more than 20 years, with lots of pioneer work in development of daycare delivery with national and international presentation and publications. She has been authored of 2 novels, The Final Conspiracy, Born Muslim in India, Boon or Bane. Lot of hidden talent. Welcome, Dr. Shruti. And then Dr. Manoj Chelani, sir is Director, Ayush Hospital and Test Tube Baby Center, Raipur, and he is Chairperson, Medical Disorder in Pregnancy Committee, POXI, Chairperson, Urogynecological Committee, Indian Menopausal Society, Managing Committee Member, ISAR, Founder, Chairperson, CG, Founder, Vice President, Raipur ISOPAP, awarded by Chief Minister of Chhattisgarh with lots of publication, and he has been editor of book on medical disorder in pregnancy and author of a book chapter Renal Disorder in Pregnancy. He has been convener of FOXI GCPR Guidelines of Epilepsy in Pregnancy and adjunct faculty Datta Meg Institute of Higher Education and Research, Savangi, Varda. He has FOXI recognized training center in endoscopy, infertility and sonography. Welcome, sir.
Thank you. Thank you so
Yeah.
much.
And our next chairperson, Dr. Jagrati Nagar, Associate Professor in Bundelkhand Medical College, and she is present President Sagar of OBG Gynae Society. Welcome, Dr. Jagrati Nagar.
Thank you, ma'am.
And I request the chairpersons to introduce the speaker and proceed for the session.
Just before Dr. Aparna is being introduced, I must say that I'm really impressed with so much extracurricular talent like music, classical music and the literature. And it is so good to know this thing like Dr. Manik, we have been like meeting. So it is so good. And we know that hidden talent. And I say join Georgia's gynecologist. You are such a talented. And my special thanks to Aparna, who is always with us to disseminate knowledge. She's always like, it is her peak time in the AIMS working, but Aparna is so particular and meticulous. So I owe a big thank to all faculties who are with us. So special Aparna, and it is really great to know about the so many talent of our members. So
Thank you, ma'am. Thank you.
I request Dr. Manik to introduce Dr. Aparna.
Yeah, sure. Thanks a lot, ma'am, for including me for this webinar. Dr. Aparna Sharma, who is additional professor, AIIMS New Delhi. She is MD, DNB, FICOG, MNA, MS. She is heading the division of maternal fetal medicine, obstetrics and gynecology, AIMS New Delhi. She is a maternal fetal medicine specialist with expertise in fetal interventions. She is secretary, Society of Fetal Medicine 2224, North Zone Coordinator, Safe Motherhood Committee, FOXI, 2020 to 2023. She is chairperson, AOGO Quality Committee 2123. My God, she has many awards on her name. Kamini Rao Oration, Junior Korean Award, FOXI Sun, IAEC International Traveling Fellowship, Imaging Science Committee Award, Rajat Roy Award 22. We welcome you, madam. I know we all will be benefited by your, I should say, whatever you will be telling us. Thank you.
Thank you, madam. And I really thank Dr. Sadhana Gupta, ma'am, for having me here on this very illustrious platform. It's interesting to have so many societies together. And I think it's a great way for, connecting so many people and so many societies together. So today we're going to talk about aneuploidy screening. So, aneuploidy screening has been happening for such a long period of time. And it's like, I really feel like, we kind of keep inventing and reinventing things again and again. So I would like to consider this like from basics to beyond and the questions in between. So when we talk about aneuploidy screening, we have so many questions in mind. And right from, who should we be screening, which tests should we be doing, what should we say before screening, after screening, what should we do when the test comes positive, what should be the other tests which should we be doing, is there a role of expanded screening, and what do we do when the NT is raised, and twins. So these are some of the questions that I would be discussing, and we would be talking about this in a question answer format. So let's just take up one by one. So if you have a primi gravida who's a low risk pregnancy, 12 weeks of gestation, 26-year-old who came to you for routine checkup. So would we be offering aneuploidy screening to her? You know, she's not high risk. She's a 26-year-old. So should we be offering aneuploidy screening? Now, what is the need for aneuploidy screening? I will offer her aneuploidy screening, but what is the need? So chromosomal abnormalities occur in approximately 1 in 150 live births. And if you look at the prevalence, it increases with maternal age. So we all know that aneuploidy screening increases, the prevalence increases with age. So that is not something that is new information. But what we really need to understand is that most of the children with trisomy are born to younger patients. So even though the older women are more likely to have it, but it is the younger women who are having it more because there are more number of pregnancies in that population. So we need to offer it to everybody. And interestingly, the CNVs, which is the copy number variations, occur independent of maternal age and occur in approximately 0.4% of the pregnancies. So this is just an additional information that I want to present it here. I will not open this to discussion or, you know, encourage a discussion at this point, because that will open a Pandora's box. So for now, we would like suffice it to say that all pregnant women, regardless of age, should be offered through an informed counseling process the option of prenatal screening test for the most common clinically significant fetal aneuploidies. So that's the first matter there put aside. Now, the thing is, okay, now we have decided that we will offer. So what should we be offering? Which screening modality would be the best? So should we be doing serum biochemistry alone, ultrasound alone, combined both, or NIPT? So we know that in the first trimester, we have some options. Second trimester, we have options. We have a combination of first and second trimester. But what is the best and what is the practical thing to do? So for all practical purposes, what we normally do and consider is that if we combine the first trimester biochemistry, that is beta HCG and PAPA, with an NT-ultrasound, we have a detection rate of 80%. 80 to 85%. So it is called 82 to 87% with a false positive rate of 5%. And why these numbers are important? So if these seem like too many numbers on the screen, what we really need to remember here is 82 to 85%, because these are some of the numbers that we need to tell to our patients. We need to tell that, look, we have offered this test, you have taken this test, and if in the first trimester you have done this test, we are 85% sure that your baby does not have a detection rate of 85%, the baby does not have an aneuploidy, the risk of aneuploidy with a false positive rate of 5%. So these are some of the numbers which become very important, and triple screen should not be done because it is less than 70%. If the patient has missed a window of the first trimester, you can offer her a quad scheme, which is 80% detection rate. So this is something that needs to be remembered. Now, interestingly, I would say that all of us who are here discussing the scenarios here would have come across something that I'm talking about here. She was a second gravida para-1 live one who was referred to me at 12 weeks of pregnancy with a previous pregnancy terminated at 18 weeks pregnancy for supposedly a pregnancy of Down syndrome. When I started looking into the reports, the record review just showed a quadruple report of 1 in 109, and a pregnancy was terminated only on the basis of a screen positive report. Now, my question is, have you heard about it? I'm sure you have. The point here is we have to be very, very careful in scenarios, because screen positive does not mean affection. Screen positive means it requires further testing. In a study from India, among the screen positive women, about 9% underwent termination of pregnancy even without confirmatory testing. And that is how lightly we are taking our pregnancies, and that is how seriously we are taking our screening tests. So what is really needed here is a pre-test counseling. A pre-test counseling, because a screening test is not a hemoglobin test, right? It is not like any other blood test that you just offer this to anybody without explaining the meaning of this test. So a pre-test counseling, inform regarding chromosomal disorder, review, inform regarding the specific risk of carrying a fetus, discuss the risks and limitations and benefits of the test. Tell them that if the test is negative, what is the residual risk? What is the detection rate? If the test is positive, then it needs to be confirmed. and what are the options for additional testing. So a pre-test counseling is extremely important when we are offering a test. So now we go on to the in-between questions which come up all the time. So now, this is the same lady. So I'm just, roaming around the same lady because these questions keep coming up, and you have all sorts of women coming up and saying, Doctor, I am a very well-read woman. Now the Google has told me that there is a test called NIPT. Now in this 26-year-old lady, primigravida, low-risk pregnancy, is the role of NIPT and what are the indications for doing NIPT? Now, so the point is that what is the position of NIPT in the screening algorithm? So if you go by ACOG, this is a very definite say that this has definite role as a secondary screening method where NIPT can be offered for women at high risk of aneuploidy, which would increase women with age more than 35, ultrasound suggestive of increased risk, like soft markers or any other increased risk, personal or a family history of prior pregnancy, first or second trimester screening test positive, or a parental balanced translocation. So the number one condition is when there is a secondary screening. That means you have a woman who's at high risk for aneuploidy, so you offer NIPT. As a contingent screening, that means some of your screen has come positive. So when you have an intermediate risk on biochemistry, you can offer her NIPT. Now, would you offer NIPT as a population screening test? There are certain proponents who would say that why not offer NIPT as a population screening test? In India, probably the cost would be prohibitive at the present time. But yes, as a fetal medicine provider, I would tell a patient that, look, there is a test like this which is available and which can tell you by 99% sensitivity detection rate that it can detect a Down syndrome. I would not offer this test first off to anybody and everybody, but if somebody inquires to me about NIPT, I would say, yes, this is a test which is available and you can consider it doing it if you want a detection rate of 99% for a chromosomal, particularly aneuploidy, particularly 21. So that is it about NIPT. Firstly, for a secondary screening. Secondly, for a contingent when you have a risk of intermediate, primary population screening, not really recommended at the present time, but it is our duty to inform that such and such test does exist, right? So this is the reporting of NIPT where women are informed that the risk of their having 21, 18, 13 is low risk. Please remember, all the aneuploidy screening is always low risk. It is never a no risk. It is never no risk because it is always, it decreases the risk from your prior risk. So that's the a priori risk. So that is something that we always need to remember. So now people would say that, see, we have such a great test called NIPT, which has a detection rate of 99%. Then we have the NT scan. So why do you need the biochemistry now? Why do you want to do a dual marker where you have a PAP-A and a beta HCG? So the evidence, what does the evidence say? So in the study by Norton et al. In 2015, which actually established a lot about NIPT, they compared the cfDNA with the FTS, and they said that the false positive rate for for the first trimester screening by biochemistry was 5.4, while for the cfDNA was 0.06. So cfDNA had a lower false positive, while the positive predictive value of NIPT was also higher. However, if we do only NIPT, the risk of a major chromosomal malformation leaving behind is slightly higher. So if we only go for NIPT and we do not look at the other biochemistry, then there is a slightly higher chance that you are leaving behind other major chromosomal abnormality. There is a slightly higher risk. Apart from, of course, the cost factor of NIPT, which is higher. So there might not be a lot of merit in routinely going for NIPT, even in low-risk women. So that is something that we need to keep in mind. So what does ACOG say? That if a patient chooses screening for aneuploidy, then you have to either go for a biochemistry or NIPT, but you do not do them both because this is not cost effective and it is distressing to the patients, because then the screen positive analyte would further confuse them and it will not be followed by, and you end up testing more and more. So you either choose a biochemistry or choose an NIPT. So for all practical purposes, the protocol that we follow is that we follow routine biochemistry plus NT in the first trimester. That is the first trimester combined screening for all of our patients. And if a patient is high risk, then we offer NIPT in certain situations. So that is what we offer. So then we have a question that if a patient is 39-year-old, then would you offer NIPT? So as a routine policy or as a routine algorithm, we do follow a situation where if a woman is advanced maternal age, then in that situation, we do offer them NIPT, because a very important reason is that the risk of biochemistry being positive in women with increased age is very high false positivity. So in those women, we do offer an NIPT. So a 39-year-old woman coming in for aneuploidy screening, I would prefer to offer NIPT rather than going in for a biochemistry. So that's how it is placed, that for NIPT, age more than 35, I would go for NIPT. So then the question comes, and it's a very favorite question with the radiologist and also the fetal medicine people, that, and it's a very common saying that, you spent 20 years learning your NT scan. Do not lose it for an NIPT. Now that you have the NIPT, does it make sense that you stop doing NT scan? So NT scan is not just an NT scan. It is regarded as a mini anomaly scan. 60% of the anomalies can be actually detected on the first trimester scan if you are doing it. And it provides so much more information. And even if you're planning an aneuploidy screening, if you do an ultrasound, you might find an anomaly which requires a karyotype and not NIPT. It may be incorrect dating, it may be multiple gestation, it may be a non-viable pregnancy. So you cannot skip an NT scan just because you're planning to do an NIPT. So NT scan in the first trimester is a must. Biochemistry is preferable. There are certain situations where you would want to do NIPT over biochemistry, like advanced stage, like ultrasound findings, like a biochemical screen positive. So those are the situations where you would do NIPT. So ISWA guidelines, various guidelines say all women should be offered first trimester ultrasound scan, regardless of their intention to undergo CFDNA testing. If the women had a negative CFDNA, NT scan should still be measured and reported as a raw value and the centile. Now, the question is, interestingly, what is the importance of NIPT beyond 21? We always say that the NIPT is very important for chromosome 21. So this lady, actually, we had a patient, 26-year-old primey, whose first trimester screening came as FTS, came as intermediate risk. So we offered her NIPT. Now, NIPT came as high risk for Turner syndrome, XO. Now, what is the value of NIPT for other aneuploidies? So we know that the best value of NIPT is for 21. As we go down for 18, 13, and X, the value of NIPT detection rate actually goes down with quite low for monosomy X. So the detection rate is quite low and the false positive rate is quite high. So could it be false positive? In this particular case, why did it come as positive? Could it be false positive? So in this particular case, actually, this lady was a mosaic. Mother was a mosaic. So because it was a mosaic, so this lady decided to continue this pregnancy and she did not actually. So we did an amniocentesis and the baby was normal. And anyway, this pregnancy was continued. So we have to be very, very careful when we are interpreting NIPT, that it needs to be confirmed on an amniocentesis, and this was a false positive NIPT. So we need to confirm all the NIPTs with an amniocentesis before we terminate pregnancy. So now this is another case in which the first trimester NT-NB was normal, dual marker was not done, quadruple marker was high risk for T21, NIPT was done, and it came out to be high risk for T21. Level 2, it was normal, and then amniocentesis was done. So amniocentesis, when it was done, the karyotype was suggestive of no aneuploidy. So again, it was a false positive NIPT. So the point of stressing all of this is that all of your NIPTs have to be confirmed by an amniocentesis. So these are practical examples to see that you have a positive FTS, you've gone for an NIPT, then you confirm the NIPT by an amniocentesis, if it is positive. If it is negative, then you're quite clear that, okay, you leave the patient alone, leave the baby alone. But every positive NIPT has to be confirmed by an amniocentesis. Now the question is, screen positive does not mean that the condition is always present. And this is how you can prevent unnecessary terminations of pregnancy on a screen positive, because the positive predictive value is affected by a population prevalence, and there are some of the links which can tell us what is the positive predictive value of the test with the population prevalence. Say, for example, for trisomy 20, at the age of 35, the population prevalence, the positive predictive value is up to 95%. But at the age of 20, the positive predictive value is 80% only. That means even if the test is positive, it is not necessary that the baby is going to be positive. So depending on the background of the patient, your test positivity is going to get affected. So whenever you have a positive test, you need to confirm it by amniocentesis before you terminate the pregnancy. So as I said, the false positivity could be because of mosaicism. Like I said, in that patient, the mother was Turner mosaic, or it could be because of a vanishing twin, or sometimes because of cancer. If your NIPT result is negative, the patient should be offered a morphology scan and additional counseling according to your findings as required. Now, sometimes the lab would say that there are failures in NIPT, or the NIPT has failed. Now, in a very large series, it was seen that if it has reported a test failure, then there is an increased chance of aneuploidy. So if a lab has reported a test failure, then it is better to go for an amniocentesis rather than repeat testing. A lot of geneticists would prefer a repeat testing, but you must also think of the gestational age. If the gestational age is already advanced, you might go directly for amniocentesis, or if it's an early gestational age, sometimes a single repeat testing may also be offered. So ACMG says offer diagnostic testing for a no call on NIPS because there is an increased chance of aneuploidy. Now, a lot of genetics lab would come to you and say, Ki NIPT say they will look at the whole chromosome, all 23 chromosomes. Now, is there any merit in that? Well, there is not much merit right now. We cannot say what is going to happen in the future, but right now, the screening for other chromosomes apart from the 5 chromosomes already mentioned is not recommended because it has not been validated. For the practical purposes, we only look at the 5 chromosomes on NIPT. So, because if you find something else, then we must include the geneticist to know how to counsel, to know what to say, because we don't even know whether we should terminate this pregnancy or not. So just stick to those 5 chromosomes for now till we have further data. So the next scenario in aneuploidy is raised NT. So if you see an image and it says NT is 2.5, CRL is 77. So what do? The first thing is, do not comment on the length of NT alone. Ask for the centile. First thing is, look at the centile. Length of the NT alone is not important. So the NT measurement alone is not important. Look at the centile. If the NT is within the 99th, 95th centile for that gestation, then I am okay. But the same measurement of NT for a CRL, which is 54, the same measurement, but for a lower CRL will now become more than the 99th centile, then I have a problem. So between 5th to 95th centile, I do not have a problem. More than the 95th, more than the 99, I begin to have a problem. So there is no absolute value of normal NT. It should be interpreted in the context of CRL. Anything more than 3 mm would be more than the 95th for any gestation. So absolute value 3 mm, you know it is abnormal, but anything between 2.5 to 3, you must plot them on the centiles. Anything which is more than the 95th or the 99th centile, reaching the 99th centile, you have a problem. So what do you do when you have a raised NT, right? So we know if you have a raised NT, we need to look at the cardiac abnormalities, you need to look at the structural abnormalities, we need to look at aneuploidies, and then we need to look at infection screening. So normally in the second trimester, in the first trimester, around 13 to 14 weeks, we need to look at any basic problem in the cardiac, any structural anomaly. We will do an CVS, a Coriolis sampling, and then we do a conventional karyotype along with microarray. Now, if the karyotype is normal, we follow this patient up for the second trimester scan, and we look again for an echocardiography along with testing for infections. If the patient is all right, reassure. But if at any point in time we feel that there is an increase in the patient, there is increase in the nuchal translucency, and there is cystic hygroma, and there is worsening, then of course there is a serious problem. So testing for Noonan is also indicated for certain situations, which I'll be talking about. So if there are multiple ultrasound findings or a larger NT, which is more than 5 or more than 3.5 with distended jugular sacs, hydrops fetalis, polyhydramnios, pleural effusion, ascites, cardiac defects, then we need to suspect rhasopathies. And along with karyotype and CMA, we need to test for rhasopathies also with respect to raised NT. So now just a look at the second trimester report. So we look at, the biochemistry report. So when we look at the biochemistry, interestingly, we need to understand this in this concept, right? So you see, this patient has an age, she's a primi gravida at 36 years of age, IVF conception. Now you see, when you enter this report, you see the IVF here has been marked as no. She is a donor oocyte, while the age here is mentioned as 36, right? And she has a vanishing twin. Now this absolutely has no meaning. So this report has absolutely no meaning at all, because all of these entries, so this report has not been adjusted for IVF, this report has not been adjusted for age, right? And vanishing twin. So vanishing twin, you cannot even do a biochemistry in the first trimester. So we have to be extremely careful that in light of the clinical detail, does this report even have any relevance? So we need to be very careful that when we are ordering biochemistry, we have to see what we have to adjust. We have to enter the details properly, age of the donor, mode of conception. If you have a vanishing twin, we cannot do a biochemistry in the first trimester. We must be doing biochemistry in the second trimester. NIPT can be done if you have adequate time between the vanishing twin and the timing of NIPT, and you can offer amniocentesis if you require. So you need to adjust when you are interpreting screening tests. You need to adjust for the age of the mother, the gestational age, previous history of Down syndrome, weight, ethnicity, ART, twins, diabetes, and smoking. Without this, if you have any test which has come to be positive, there is absolutely no meaning to interpret these tests. So please check on these things. Now, is there a role of expanded conventional first trimester screening? So now the labs are coming in. कि first trimester में ही सारे test कर डालो. You add PLGF, you add this thing, inhibin, you add all of it. So you have beta HCG and PAPE. To that you add alpha protein, you add PLGF, you add inhibin. So this is the penta marker of the first trimester. Is there any merit in doing this? So, well, it has been reported that they have very high detection rates. There are advantages of screening for early preeclampsia, and I completely endorse doing early screening for preeclampsia. In fact, as obstetricians, like you said, obstetricians are fetal medicine people. But first, let's be obstetricians completely, wholeheartedly. Before we screen for aneuploidy, screen for preeclampsia. Screen for preeclampsia at least by a history, biochemistry, and at least by a history and a blood pressure. And if possible, do a PLGF. If you think your patients can afford a PAPE, why not do a PLGF? Now I advise PLGF for everybody. The belief that we are a poor country is a myth. And if we can offer PAPE, we must offer PLGF. And I'm very, very, very passionate about it, that because we need to screen for preeclampsia. So even if your alpha fetoprotein and dimeric inhibin may not add value, if this test can offer PLGF, and most of the labs do offer expanded this thing at the same cost as your current double marker, and you must ask your labs to do that, because labs in Delhi are doing that. So if you're able to do that and you're able to give a preeclampsia risk to your patient and you can add aspirin, you are saving lives. And I think I'm very, very pro doing PLGF in the first trimester, and that is something that we need to think about. So regarding aneuploidy screening, there might be some advantage, but I would not advise it only for the purpose of aneuploidy screening at the present time. Now for twins, very, very simply put, you can do first trimester beta HCG PAPE plus NT. That is recommended by everybody, that we must do the first trimester screening, which is as good. Only NICE says quadruple, but we don't really do quadruple in twins. None of the other societies do recommend quadruple. So we must do the first trimester double marker with NT for the twins. NIPT now is widely validated for twins, and we can offer NIPT by various techniques in twin pregnancies, which is very, very all right. Now, what to do in vanishing twins? The problem is you cannot offer biochemistry in the first trimester, because the time period between fetal demise and the testing, you have to have 8 weeks. And if you've had a cardiac activity or a fetal pole, you cannot have testing by the time of 13 weeks, which is 8 weeks. So 5 weeks plus 8 weeks is 13 weeks. So you cannot do first trimester biochemistry. Then you can probably do a second trimester biochemistry, which is anyways not advisable in twins. CFDNA you can do, but there has to be at least a 16 weeks gestation difference between fetal demise and your NIPT. So you can probably do screening in vanishing twin. The problem in vanishing twin is that the PAPE persists at a higher level. So you don't know whether the PAPE is high because of a normal pregnancy or because it is persisting from a vanishing twin. So that's the problem. So either we only use beta HCG or we use PAPE, which is corresponding to the vanishing twin. So I think that is all I would like to say. This was actually an update on the current existing themes of aneuploidy, not the very, very basic things about aneuploidy. So I would conclude by saying that the ideal first trimester screening is combined screening. Do not repeat a high risk report. Sometimes a biochemistry has come high risk, the patient is not ready to accept the report, people start doing again and again and again and again, and that's not going to help them, because the first high risk report will remain in their mind. NIPT can be offered as a secondary screening. Invasive tests can be offered for high risk screening reports after proper counseling. The desirable screening protocol in the first trimester is the first trimester biochemistry. If the screen is high risk, refer for NIPT or invasive testing. If the screen is low risk, then just offer a sonographic evaluation at 18 to 20 weeks and discharge from the screening protocol. Then if it is intermediate screen, then we might need to consult a fetal medicine person for the intermediate screening, which is 1 in 250 to 1 in 1500. Now, for the intermediate screening, I would say, is the integration between the first and second trimester analytes possible? I did not cover the integrated screening for a reason, because there are very, very few labs who are actually able to integrate the first and second trimester analytes. Actually, I have done it only twice in my experience, because the labs have to be the same. You cannot get the first trimester and second trimester from different labs and try to integrate it. Now, if it is possible, then you can calculate a new risk. If it is not possible, then possibly do a genetic sonogram and a soft markers, which I think Dr. Sadhna is going to cover. NIPT can be offered as a contingent test in the intermediate group. If NIPT is high risk, then offer invasive testing. A patient who comes in the second trimester, offer quadruple testing. If the screen is high risk, which is more than 1 in 250, then offer NIPT or invasive testing. If the screen is low risk, then discharge from just do a sonographic evaluation and discharge from screening protocol. If there is no biochemistry, then of course you just have to rely on your ultrasound report. And then of course we now offer NIPT and say that of course you do not have anybody who's coming in 22, 23 weeks and no aneuploidy screening. We do offer them NIPT and say that, look, this is something which is available. If you want to go ahead with it, you can go ahead. So I think that is all I would like to share here. Thank you very much.
Thank you, Dr. Aparna. Really a very crystal clear message. And especially regarding PIH also you have mentioned very clearly. So thank you so much for a wonderful talk.
Thank you, sir.
Madam, I have one question. I had, can you hear me, madam?
Yeah.
Yeah.
Yes,
There is a patient who is 29 years old. She has previous normal female child. Now she came to me at 18 weeks and her T21 is 1:5. So I offered her NIPT. And the NIPT is yet to yet to give the report. So how I go ahead? Should I, if it is positive?
So ma'am, here actually, so thing is that you have to offer her both.
Both.
In that case, like you, so when you offer both, right? So you offer her NIPT and you offer her amniocentesis.
Amniocentesis, both.
Yeah, so both. But and then especially when the risk is 1 in 5. So we would kind of counsel that, listen, the risk is very high.
Very high.
You might want to go for amniocentesis.
Okay.
Right.
Okay.
And there has to be a very strong reason why the patient would not want to go for amniocentesis in this particular case. Right. So either the patient did not understand, or we sometimes, the perceived risk of amniocentesis is very high. While you need to quote a risk of 1 in 1,000. Right. In experienced hands, the risk of abortion is 1 in 1,000. And that's the numbers we quote. And actually, it is not more than the background risk of abortion. Now, so to say. Right. So with a risk of 1 in 5, you might want to say that, look, your risk is very high. You might want to also. So you have to, and ultimately it is the patient's choice. Now, if NIPT comes negative, you say that, listen, 99%, we are sure that your baby is all right. Okay. So you just leave it to rest and, leave this pregnancy alone now. Now that she has chosen NIPT, the choice had to be done earlier. Now that she has gone for NIPT, the results come normal, leave her alone. The results come positive, go for amniocentesis. Okay.
One more question, madam. On Sunday, I operated one patient who had IUD at 26 weeks. She came with 190, 100 BP and of course APH. When I dug into the history, first baby was in first pregnancy also she had PIH. In second pregnancy also she had PIH.
Yeah.
She was operated in medical college. She has a live female child. Abhi bhi she had female. लेकिन ये लोग जल्दी आते नहीं. So whatever you have told me to get it done, early screening.
Yeah.
तो अब उसको fourth pregnancy में हम क्या बताएं?
नहीं तो मैम इसका तो definitely in as soon as the pregnancy conception, first of all, APLA screening should be done in the inter-pregnancy period.
Yeah.
You should screen for
But she has BP, high BP. There is clear-cut history.
No, so it doesn't matter. At least you screen for APLA, na? So whether you need to give her only aspirin or you need to give her heparin also. So that would depend on that. Yeah.
And what about the renal artery stenosis? Because we don't know in between whether she has hypertension
I mean, that
or not.
workup you need to do renal artery Doppler and see, clean, look for medical renal disease, all of those things. But APLA screening is important. Yeah.
Okay.
Thank you very
Thank
much.
you. Thank you, ma'am.
So our all other chairpersons to put the comment, and we warmly welcome Dr. Mandakini Pradhan. So other chairpersons to comment, yes, on excellent talk, Aparna. It is like you are such a clear message, which is so much of need, and that is the actually basic theme of the E-Classic for clinicians, so that our clinician get the clear message out of it, like what we are having a lot of evidence and all inconsistent. Excellent talk. So Anju, please invite our all other chairpersons to comment and before we go to welcome Dr. Mandakini Pradhan.
Yes, madam. I would request Dr. Manoj, Dr. Mandakini and other Dr. Jagrati and Dr. Abha, if they can comment, give their expert comment, and as the talk had been excellent, wonderful.
Can I come in? I'm Dr. Mandakini.
Yes, madam. Namaskar.
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 You are our guest of honor, so
Yes, madam.
I have to introduce as a guest. That is the protocol. So Dr. Mandakini Pradhan, great friend since like what we can say, I think even a long time. It is, we can say it is sometime I say कि कुछ पुराना जन्मों का बंधन होता है. So Dr. Mandakini Pradhan, she is professor and head Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, Uttar Pradesh. She is one of the very few person who has done DM in medical genetics. She has been the chairperson Genetics Fetal Medicine Committee of the FOGSI from 2019 to 2022. Has been recipient of many awards, Bharat Gaurav Samman by World Human Rights Protection Organization, Women Achiever Award 2021 by Governor of Uttar Pradesh. And she is one of the person with all in the north. She is always approachable, what is so very good for all our patients. Even we give the WhatsApp and take care of so good in the like patient. She is so approachable and doing a lot of great work in the Sanjay Gandhi Institute as well as at the various professional bodies, and a wonderful tenure as a chair of the FOGSI Genetics Fetal Medicine Committee. So we want that you be with us throughout, and we look forward for your address as well as your all the like pulse of wisdom. Dr. Mandakini.
Yeah, thank you, Dr. Sadhana, for that wonderful introduction. I'm actually, listening to Dr. Aparna, I realized that what we see day in and day out is increased risk for Down syndrome. So we have gone on to Down syndrome. The screening protocol, yes, definitely we are little here and there. So, and multiple markers are coming up. So what we are doing is, whether we are doing correctly or not, we need to brush up and e-content or what is called as a Zoom meeting like this enhance our knowledge. And I thank Dr. Sadhana and congratulate her for conducting such wonderful topics. So these are practically difficult. And to be very frank and honest, I am in front of a patient. Just now I finished one intrauterine transfusion in front of a patient who is 28 years, and she has consented me to discuss her this thing to this audience, that she had a quadruple test which was high risk, that is 1 in 93, then went ahead and did a NIPT, and NIPT showed a low risk. Now she continued with her pregnancy, and while I am doing, this is her first ultrasound with us, and while doing the ultrasound, if you can appreciate, this gestational age is like, right now I am in front of the ultrasound machine only. The patient is here only. So this is 24 weeks. And what is there is a very depressed nasal breeze. So now we go ahead and do a detailed malformation scan. So what Dr. Aparna rightly pointed out that we need to have that malformation scan. Let us concentrate on malformation scan and let us rule out all those malformation and then concentrate on having a, we should not forget, if we are doing an NIPT, we should not forget that everything is fine and then the fetus is fine. At least being a referral center day in and day out, we see an amount of malformation without with NIPT being normal. And Dr. Aparna, in her talk, herself said that patient opted for double marker, then went ahead and did a quadruple marker, and then went ahead and did a NIPT, and then few of them they asked for a amnio. So this is a difficult situation, and we as an obstetrician should be clear about what we are doing. Next is, she's very, very lucky not to have a false negative NIPT. See, always we are saying 99%. What about that 1%? If I am sending 100 NIPT, then 1 may be negative. So there lies the crux. So we should not say NIPT is normal, low risk. So everything is normal. Please do not venture onto it. I have got my personal experience of NIPT being negative and baby being delivered, confirmed to be Down syndrome. This is in my hospital itself. So as an obstetrician, we should not tell the patient that everything is fine and then go ahead and with this, all these are screening tests. So to me, if the risk is more than 1 in 100, or what is called as a 1 in 50, 1 in 8, 1 in 5, go ahead and do a amniocentesis. You will be 100%. You will be clear. The patient goes back home, and then you are clear. So, yeah. So, Dr. Aparna, that was an excellent talk, and we continue discussing this topic, probably evolving topic. Thank you so much, and thank you. And looking forward for this session.
Thank you, ma'am.
Thank you, madam, for your expert thoughts. I think we can proceed to the next talk. I request, madam, please unmute yourself. I request Dr. Asha to continue.
Yes. Thank you, Dr. Anju. So after that extremely excellent talk by Dr. Aparna, we are going to have another one by Dr. Sadhana Gupta, ma'am, on understanding ultrasound soft markers. May I have her CV, please?
Thank you.
May I have the CVs, please? So,
First chairperson, Sasha. Dr. Asha. Yes.
yes, please, Dr. Sadhana. Just a minute. We need to introduce you a little. थोड़ा तो बोलने दीजिए. गायब हो गया. So it is a great pleasure and honor to introduce Dr. Sadhana Gupta, ma'am, who has been the co-chair of CEPHOG and who is the co-chair of CEPHOG NCD committee. She's been the FOGSI representative to CEPHOG for 3 years, Vice President FOGSI 2016, ICOG Governing Council member for 6 years, with Best Governing Council Award 2021. More than this, I would like to just say that she is standing for president this year, and she has been working for FOGSI for more than 20 years. So it is a request to support her wholeheartedly, and in the form of votes, all of you please vote, and voting will start on 1st August. And now I would like to introduce the chairpersons. The chairpersons, Dr. Vandana Gupta, ma'am, who is an MBBS from MLB Medical College, Jhansi, DGO, KGMC, Lucknow. She is working in Katni for the last 22 years, owner and director of Om Shanti Maternity Hospital, Katni, President, Katni Obstetric Gynec Society, founder, and past Vice President Cox, Katni Obstetric Gynec Society. She is currently the Vice President, IMA Katni. Next, please. Then we have our own Tabassum. She is currently the President of Raipur Obstetric Gynec Society. She is the Vice President of IMA Raipur. She is an MS with Diploma in Minimal Access Surgery, Diploma in ART. She works works at and is the director of Jubesta Hospital, Raipur. She has an Foxy recognized ultrasound center. She's been organizing secretary of many conferences, also been the organizing chairperson of annual state conference of Chhattisgarh, organizing scientific committee member, embryology conference of ISAR at Raipur. Her special interests are high-risk pregnancy because she believes education is empowerment. She is young, she is dynamic. Welcome, Dr. Tabassum.
Thank you, madam.
We have Dr. S. Birthere, who's a senior consultant obstetrics and gynecology from Bilaspur. Then we have Dr. Uma Nigam. She's a consultant obstetric gynae at Katni Nursing Home. She's an MBBS BGO from Medical College, Jabalpur. Immediate past Vice President IMA Katni, President Jagrati Society Katni, Joint Secretary of Paryavaran Vikas Sandharan Samiti Katni, member of Giants Saheli, and her special interests are high-risk pregnancy and adolescent healthcare. She's really a great obstetrician and is taking care of a few of my patients at Katni. So welcome, Uma ma'am. And over to you all to now take over and introduce the topic. Over to you.
Thank you, Asha Jain madam, for those kind words. Am I audible?
Yes, you're audible. You're audible.
It is our proud privilege to be in this very nice CME, which is held and which is organized by none other than our own Sadhana Gupta madam. I would say Sadhana Gupta madam is a knowledge tree of Foxy, and she's got passion in imparting knowledge, and her zeal is unmatched. We have had her recently at Raipur, and whole society loved her so much. So I hope that everyone present here today vote for her, and all the best to you, madam, for your future endeavors. Today we are going to hear improvement and understanding soft markers by Sadhana Gupta madam. So the stage is all yours, ma'am.
Thank you. Thank you, Dr. Tabassum, Dr. Asha, for your loving word. And yes, we are together for learning, sharing for benefit of everyone. So after the excellent talk by Dr. Aparna, which sets the stage for screening, I will cover the next step, which is actually confusing every clinician, because people, they are coming from this doctor to that doctor because they have found something in the second trimester scan. So a wonderful paper by Dr. Pankaj Desai, soft markers are we lost. So let's see, I will like to cover like all soft marker in a short span and bringing clarity that what every soft marker means in the implication and interpretation. So this was the journey, right? What Tabassum was saying, that I was just like a few months ago at Raipur, Bilaspur, and wonderful the time we had, and I had even Tabassum organized to get me to the movie after I think almost 20 years I went to movie theater. So thanks for all the loving friendship which I have enjoyed thoroughly in my 30 years with the great friends, with the vision, with the knowledge, with the dedication, and trying to do the best for their patient and the people. So soft, what is the word itself says that soft, because it may not visible to many, it might point to something significant, yet it may be benign in their own, but the observer may have the knee-jerk reaction and can cause a lot of anxiety and apprehension in clinician, patient, and family. So it is day-to-day scenario. What Aparna says, we all know that we have a chromosomal aneuploidy in a good number, that is 0.1 to 0.2%, and out of this, the trisomy 21 is the most common, and other what we detect, the other three anomalies. So method what we have use for the carrying like screening, that is the age, biochemical marker, prenatal ultrasound, and amniocentesis. Yet the issue why the soft marker remains still important in our practice, because the invasive procedure always have their own complication and people might not accept very readily what we have in day-to-day practice. So ultrasound markers can be major markers as well as the soft markers for aneuploidy. And as an obstetrician, I'm not a fetal medicine person per se, but throughout my journey with a very, very long, doing a lot of ultrasound right from the beginning, as ultrasound machines evolved, I also evolved. And actually, we take the care right from the preconception to the delivery and to the neonate and to the childhood as well. So as an obstetrician, actually, we have an opportunity to see the things, what went wrong, what was missed, and what decision we took, was it good or it was not good. So it is all about learning. The one thing I will like to say to every clinician today, that a lot of technology we have, a lot of research but we have to be, what Aparna said, we have to be first obstetrician and first be a doctor and the human being. So we try to solve. Sometimes I say that don't look at the fetus with a eye of something, finding something abnormal in the fetus. Respect every life, because every life want to live. So as an obstetrician, our role is to multi-dimensional at multiple level, right from the disease to the genetics to the psychology to the spirituality. So this is the thing which we have to retain as a doctor. So what we have, the major marker and the soft marker. So we have all the marker, which I will discuss one by one to them. And the first type, what is the major marker? So if we find major marker, there is no confusion about it. You have this structural abnormality, you refer to fetal medicine for amnio. Sometimes it is so gross that we opt for the termination. But the issue remains with the soft marker for the aneuploidy. So why it is important? Because these markers are not pathognomic, because they can be seen on fetus, but they have been still analyzed and used to screen for the Down syndrome and other aneuploidies. We have a lot of difference. Yes, we have got it, something an inconsistent result. And initially, like 15 years ago, we were having a very quick and the knee-jerk reaction when we used to see the intra-echogenic cardiac foci. But now we have to understood, because we have observed for a period of time and we have correlated when the newborn are being born. So the soft markers are why it is important in the past, because the ultrasound we are doing anomaly scan, and the soft markers, they are more found. The key point is that they are more found in the fetus with the anomalies and might be associated with chromosomal abnormalities, yet they can be found in the normal fetus as well. So these are the few soft markers which we get the reports daily: ventriculomegaly, choroid plexus cyst, all the things which I will take one by one. And what is the concept and need behind soft marker, and what is their role in the current Indian scenario of the role of soft marker? Because we have the trisomy risk, we find that it is a risk which we have to exclude or confirm that this patient is having this high risk or not. Our Indian Newborn Action Plan says that the prevention of stillbirth for the single digit and the birth genetic aneuploidies and anomalies are the important contributor to the stillbirth as well as the adverse neonatal and the childhood health. And many families in our setting, like people are coming from the diverse families for so many religious, social, cultural, economic issue, availability. So many times when we offer them the straight away amniocentesis test, sometimes they are not like that readily agreed. And here it comes the role for the observation of the soft marker as well as the interpretation. Beside this, like the scarcity, sometimes we don't have that much of fetal medicine specialists still today in our country, though this field is evolving. Then the PCPNDT and the other act, which is actually a little bit hindering issue in having that freely available of the this invasive procedure. So what we will like having that the first trimester combined screening, the first trimester screening and the second trimester screening has been taken is like by Aparna very nicely. So we will just go to the soft marker. Before that, what I said, that is the compassionate care. When we just write anything double marker, when we say do TIFA, because everybody is like going and the reading and the listening, do we counsel that there is possibility that we can find any soft marker? So even Western world says, where they might have a little bit robust system, though the Indian system is also very good, that the lack of, like, the people, the woman or the family is looking for is everything is normal, and we find that we say that no, these are too soft marker, and suddenly they are emotionally traumatized. So one gap in our system is that when we order for any genetic screening test, biochemical screening test, anti-NV scan, or the target scanning, which includes soft marker as well, that we make them, it is not a thing to be ordered, but it is the thing to be explained why we are doing, what thing we can find out, and so that they are really ready, and that is called the respectful reproductive health. So this is one thing. This actually some slide is coming over, but just maybe. So just actually one bar is coming to my quickly. So the obstetrician, because, and when the obstetrician get these reports of the soft marker, they are so confused, and many times what we say, they have been advised the termination. So always we have to understand that what is the value of each soft marker, because it is the life what we are dealing with. So respect everyone viewpoint, that is the important thing, fetal medicine, obstetrician, and the patient and family perspective. So coming to the second issue, that is what is the low risk versus high risk population. So in low risk population, soft markers are found in 5.9% of fetus at second trimester ultrasound, out of which 5.1% are isolated and multiple marker at the 0.7%. And on first identification, 95. This is the research what we say, what is the incidence of the soft marker which we can have in the normal as well as the aneuploidy fetus. So coming to the ventriculomegaly. So first of all, that how do you measure and how do you interpret? This is very, very important. So 10 to 12 millimeter is mild ventriculomegaly, 12 to 15 moderate, and 15 millimeter is severe. And if it is more than 15 millimeter, we think that it is we have distinguish it from the hydrocephalus. So this is very important, that the right section of the head and the right measurement. How we interpret, it can be normal variant, it can point to aneuploidy or the genetic syndrome, it can also point to primary brain abnormalities and the congenital infection and cerebrovascular accident, as well as the intracranial hemorrhage. These are the pathologies which can cause the varying degree of ventriculomegaly, and isolated mild and moderate ventriculomegaly regress or become stable in diameter, in contrast to severe. So when it is mild and moderate, we need to have the further investigation, and the screening for the viral infection is very, very important when we see the ventriculomegaly. So it is not only pointing to the aneuploidy, we have to think for the other cause of ventriculomegaly, especially if we find the periventricular echogenicity, calcification, pseudocyst, or intraventricular synegia by the appropriate immunological test, if possible avidity test, and then confirmation that the fetus is infected or not by the DNA amplification test using PSR. So what is the implication of ventriculomegaly? It may be the pointing to aneuploidy, but it is also related to the neurodevelopmental delay in the childhood. If it is mild, then the risk is less, but if it is a moderate to severe, there are chances that the baby can have the neurodevelopmental delay, and we have to counsel this also to the patient and the family. And the second thing is the exclusion of the viral infection. So this is very important, that what we know when we see ventriculomegaly, we have to see that it is a mild, moderate, severe. It is increasing or not. It is not showing the sign of the viral infection and like associated the CMV or the toxoplasma, and do the test accordingly. And we have to counsel that we have to follow the fetus as well as the neonate for the further. The choroid plexus cyst, which is a very common finding, we find it is a typically appear as a well circularized echo-translucent area within choroid plexus, and it typically regress by 23 weeks regardless of karyotype. So this is important, it is going to regress. It can be single or multiple, unilateral or the bilateral. Important thing is that if it is isolated choroid plexus cyst in otherwise normal low risk pregnancy, it has got a good prognosis. It is not considered a structural nor functional brain abnormality. And if there is isolated choroid plexus cyst with a normal karyotype or the first trimester screening normal, it is not going to affect the child mental and motor development after birth. So this is important that as a isolated choroid plexus cyst, it is not that pointer to the aneuploidy as well as the future neurodevelopmental delay of the baby and the child, and the risk for the amniocentesis like invasive test is not justified. However, we have to look that it can be pointer to trisomy 18 in certain situation in high risk case or the other soft marker, and we have to look for the clenched fist and the overlapping digit. So when there is a choroid plexus cyst, it is not the indication for amniocentesis. Secondly, it is an indication for very detailed evaluation of the fetus, including digit and the clenched fist, which we have to give the time. But the isolated choroid plexus cyst is not an indication for the amniocentesis. So this is the takeaway, and it is not going to affect the child's neurodevelopmental cognitive compromise in the newborn. It is not related to that. Then the absent or the hypoplastic nasal bone, which we see 2.5 millimeter in mid sagittal. So right, like methodology, that is very, very important. And it is again important that we find the absent or hypoplastic nasal bone in 73% of the trisomy, which is not visible, but we can found especially the some ethnic variation. So it may be the part of the normal fetus as well. So it is still the absent or the hypoplastic nasal bone is a strong marker for the aneuploidy. And when we find it, it is important that we offer her the invasive studies to the confirmation or the exclusion of the aneuploidy. So this is very important, and the nasal bone measurement is a part of normal nuchal translucency scan, and what we say that we have to correlate all the findings. Thickened nuchal fold is the very strong soft marker, and again, the right place, it is defined as the thickening of skin and subcutaneous tissue, like on the posterior aspect of the fetal neck. Some says that is 5 millimeter is cut off, or it is a 6 millimeter, but the right measurement is very important. And if there is a thickened nuchal fold, that it is like a strong pointer to the presence of the genetic aneuploidy. And again, it warrants that we offer her the definitive test. Whether NIPT is there or not, we have an experience of Dr. Aparna and Dr. Mandakini. So to us, it is always better to go for the confirmatory test and not going on like spending time. So karyotyping should be offered when there is a thickened nuchal fold. So this is the takeaway. And the second, what we say, why this good anomaly scan, what we say, the second trimester scan should be very, very important, because beyond it, when there is a thickened nuchal fold, the fetus has to be looked for the congenital heart defect with the particular attention for the echo. So this is important, that it is one point is the aneuploidy and second is the looking for the heart. the cardiac defect in this fetus very, very thoroughly by the expert. So many times the obstetrician are doing very good ultrasound, but when we find just type of nuchal thickener fold, this is the time that we like refer the person to the best ultrasoundologist or the fetal medicine specialist. Echogenic intracardiac foci is one of the most common report which overall obstetricians get it. So it is found in 3 to 4% of all normal fetus and 25% of those with trisomy. So these are the numbers which actually makes almost a very little sense to the patient and the family, because they want to know about this fetus. They are not at all interested. But as a clinician, we are only compelled to share this knowledge. So first say that it is to be diagnosed on the 4-chamber view of the heart, right direction, that it is not only the specular reflection of papillary muscle, it is visible from all the angle, it is seen as the independent of zone of specular reflection. So this is very important, and that's why I say when we find these sort of issues like a soft marker, it is always better to send the patient to the best ultrasoundologist or the fetal medicine person. So important thing is good news that the echogenic intracardiac foci, the isolated foci is not associated with Down syndrome, and risk is much lower than the procedure related loss. So it is not an indication for the invasive procedure, and especially with the first trimester or the NIPT screen is negative, it is considered as a normal variant. So this is studies does not suggest for the diagnostic invasive test using isolated IEC in low risk women. And this message I want to give to all who are hearing, that this is very important. Beside this, the presence of echogenic intracardiac foci, the echo is not recommended. So with nuchal fold thickness, the echo and the fetal cardiac status is to be followed, but with echogenic intracardiac foci, detailed echo is not recommended, and neither the neonate, it has not been related that the neonate has any cardiovascular compromise performance in the childhood. So as an isolated finding, no further ultrasound, no fetal echo are required. This is very, very important message I want to give. Echogenic bowel, which again a very common thing, which is like the patient is coming with us and it is a fetal bowel. When we see the fetal bowel echogenicity, it is like related. It is as echogenic as the bone. So in 3rd trimester, it is relatively common finding with, we don't know, but it can point to something other than the aneuploidy, like the meconium peritonitis, we will just say, and it also resolves sometimes spontaneously. So the technical factor of the echogenic bowel is very, very important. We must identify it is grade 1, grade 2, grade 3, that is what is the echogenicity, and it has been proposed by certain authors that it is a diffuse, mild echogenic, diffuse or moderate echogenic, focal and very echogenic, and the bone echo. So that grading also we have to look into it very, very carefully with a good setting of the ultrasound settings. And when we see the echogenic bowel, it can point to the many cause. Actually, it is not the one cause. It may pointer to the congenital viral infection, aneuploidy, intraamniotic bleed, severe uteroplacental insufficiency. That IUGR is some of the very, very important cause of the bad obstetrical outcome in our country. Meconium peritonitis, cystic fibrosis, thalassemia, as well as the fetal anemia. So the echogenic bowel at time of 2nd trimester ultrasound is an important finding. We must do a detailed ultrasound for other anomaly, maternal serological test for the CMV and toxoplasmosis. And if you think that the immunology is suggestive of it, we have to see that the fetus is infected or not by the amniocytosis, in which we can combine the karyotyping with the CMV and the toxoplasmosis and the parvovirus infection. Cystic fibrosis carrier testing for the both the parents as per the clinical spectrum. And these fetus need a close serial growth scan because these fetus are prone to intrauterine growth retardation. So some studies says that sometimes they have a post-operative, some intestinal problem and surgical risk, but studies are inconsistent about it. Short long bones, again, the short long bones and the skeletal dysplasia are things where our like a obstetrician are getting a lot of legal issues about it. So important thing that we have to measure the femur, and if it is shorter, that a femur is considered shorter when measured to expected ratio is 0.91 and humerus when it is expected ratio 0.89. So it is a time that we like follow all the bones very, very carefully, because short long bones is an important pointer to the aneuploidy, because the many like the percentage for the short long bones with the aneuploidy is quite high, and more so with when there are bilateral humor and the femur are short, then it is a better finding. It is less pointing to the aneuploidy. But if it is a isolated short humerus or femur, it is more related with the aneuploidy. Beside aneuploidy, the fetus can have skeletal dysplasia, fetal structural anomalies, preeclampsia, fetal growth restriction, and stillbirth. So it is not only pointing to the dysplasia, skeletal dysplasia, it also points to the preeclampsia and the fetal growth restriction, and sometimes suddenly the unexplained stillbirth, because short femur length and the humerus length may be an early sign of placental dysfunction and warrant increased antenatal surveillance with frequent growth assessment and the blood pressure measurement. So what we say that the bilateral shortening is a little bit reassuring than the isolated femur or the humerus length. Pylectasis, when we have a more than 5 to 7 millimeter, like if the kidney, the pelvis dilatation, we called it as a pylectasis. If it is more than 7, then we have to think that they have to differentiate from the hydronephrosis. So measurement less than 5 millimeter are normal and should not be reported. And pylectasis may also be referred, like we can have a different terminology, like a mild renal pelvic dilatation or a mild hydronephrosis. It can be seen in the normal fetus, and sometimes it can also point to the aneuploidy. So again, there are many numbers in the studies, but actually the numbers are sometimes very confusing for the clinician, for the patient. And one message I want to give, that in absence of other structural anomalies or soft marker, the risk factor for aneuploidy, amniocentesis for isolated pylectasis is not warranted. So the invasive or the confirmatory test not warranted if the fetus is having only the mild pylectasis. However, this fetus has to be followed, that there is a progression of pylectasis, or when there is a progression, the fetus need close surveillance as well as the close checkup and the care into the childhood, in the immediate childhood, because postnatal dilatation, like a progressive dilatation of pylectasis, is related to the worst outcome. So mild pylectasis is an isolated finding in fetal Down syndrome in approximately 2%, but in absence of other risk factor, it does not justify invasive diagnostic procedure. And last, cisterna magnetum magna, it is the visualization can be sometimes challenging, and the prenatally diameter should be less than 10 millimeter. What are the implications? Usually benign, however, there can be sometimes increased risk of fetal chromosomal anomaly, but it is always to be considered when we have the multiple soft marker as well. Single umbilical artery, again, overall, people are so much like concerned about that this is single umbilical artery, what is the risk for the fetus? So important thing, yes, it can be associated with the intrauterine growth restriction, and it can have certain, so thus these babies need the close follow-up. This is important. It needs that the fetus is to be have the detailed scan for the kidney and heart, and isolated single umbilical artery has not been found to be significantly associated with aneuploidy. So these fetus need only the close observation, not the like a confirmatory test for the amniocentesis. So the absence of marker, now with this, all these what we have known about it, if these soft marker are absent, are they important? Yes, they are important. If especially in the high risk population, if the woman is 35, 39-year-old, have something intermediate risk for the screening test, if these soft marker are absent, that reassure the family that the risk of aneuploidy can be less. Again, the strong marker, I will be just going quickly, that the increased nuchal thick nuchal fold and the absent nasal bone. These are the few thing, and the isolated short femur length and the humerus length are the strong marker. So where is the place of all these observation? I've tried to give the clear message and understanding every marker, that what is not that is hard marker, what is not that is strong, and what is the strong soft marker. A few things always the scoring system, because scientists always work on the scoring system so that we can have certain the clinical protocol about it, and everybody says, so if we include that 1 marker, 2 marker, 3 marker, which is the strong marker, addition of maternal age, then it can solve a little bit our clinical issue. And few studies found that these markers like ISS and aura are good in the clinical practice. Beside high risk versus low risk population, so this is important that in low risk population, how the presence of these markers are important. So in high risk, absence of soft marker is reassuring. However, in low risk, when there is an aggregate or cluster of marker or the increased nuchal fold thickness or the short humor length, they should be taken in account for the consideration for the confirmatory test. NIPT, I think everybody has attended. Sometimes they may help, sometimes they may not help. So I'm not going to go for the NIPT, yet it is important because I will be concentrating that how we take every soft marker, how we measure them, how we keep them in the whole clinical spectrum, and how we understand every soft marker. This message we want to give to every clinician to save a lot of tension, anxiety, sometimes unnecessary and sometimes overlooked issue. So sonography cannot be used to diagnose or exclude aneuploidy. This is very, very important. Ultrasound is non-invasive method which everyone likes. Management of each soft marker is different, yet we can have few generalization if there is more than one soft marker, if patient older than 35 years, or if multiple marker screen is abnormal, amniocentesis should be recommended. Nuchal fold thickness, short humerus, or the major structural anomaly carry high risk of aneuploidy in both high and low risk population. Isolated choroid plexus cyst and echogenic intracardiac foci as an isolated marker in otherwise low risk population for fetal aneuploidy amniocentesis is not indicated. Besides this, always inform council that what you are going to do as a FOXy presidential candidate. I'm really looking forward that we not only take consent for so many procedures, we take like a written good in the multiple language that what we are doing, what it is for, so that it helps in like having the good information, a good what is information and a respectful information that what test we are doing for the what reason and what are the further implications. So this is something very important gaps in our healthcare, because we are having a lot of technology, but we don't know how to turn up into the compassionate and a very like what a positive experience to our patient. So see well, interpret well, act well, and above all, understand life, because understand life before you intervene. So they say the world has become too complex for simple answers. They are wrong. And I request everyone to vote and support my candidature in full number, because this is the time that you vote for the person who have worked with the commitment and conviction and the dedication in the longest period in our federation and for our fellow going. So I am ready with my vision. Do scan this QR code to get my all clinical updates. And thank you very much for always being together. Thank you very much.
Thank you, ma'am, for that way forward and teaching us the concept behind the soft markers, because most of the times the clinicians are confused after seeing the sonography reports, because I have myself seen so many patients getting some reports with intracardiac echogenic focus, and they have been advised echo and all those kind of things they do happen. So your talk has brought so much clarity today, and it's definitely going to improve our clinical practice and how we are going to benefit the patients also, and the importance of significance of soft markers and also the non-significance of soft markers. That is very important. Also, सॉफ्ट मार्कर्स एंड हार्ड सॉफ्ट मार्कर्स, कौन से सॉफ्ट हैं, कौन से हार्ड सॉफ्ट मार्कर्स है. So thank you, ma'am, for bringing out this to so many people today, and many people are going to benefit by this talk today. Thank you so much.
Thank you, Tansu. Dr. Mandakini Pradhan or our other chairpersons.
I would request Dr. Uma, other chairpersons who can, if they can have some input. It had been an excellent and wonderful talk by Madam. So, if not, Dr. Ava, would you like to comment something?
Yes, a very, very informative talk, ma'am, and very clear-cut points about the markers. And also, so many times these single markers like single umbilical artery and all, they are only pointing towards IUGR, many of them. So we have to keep like what it may be a aneuploidy, but sometimes they are not very significant, but they may cause clinically, they may implicate that there is intrauterine growth restriction. So madam, thank you very much for a very elaborate talk on the soft markers. And we really, we could revise it all. Thank you so much for your clear-cut talk.
Thank you so much, madam. It was excellent talk, but all the time when you read, no, that comes out to some new things. कभी ऐसे नहीं लगता कि हमने आज पढ़ लिया तो दूसरे बार में हमें कोई कंफ्यूजन नहीं होगा या हम बिल्कुल क्लियर कट होंगे. हाँ, whenever I attended this, मैडम, मैं तो हमेशा फॉलो करती हूँ मैडम का वो. पूरे टाइम कुछ ना कुछ हमें ऐसा लगता है कुछ नई चीजें करना है या कुछ हमने कुछ मिस किया है. That is the main thing, मैडम ने इतना अच्छा क्लियर कट वो किया किसको करना है, when go for invasive procedure, when may not. But excellent talk, Sadhana madam. You did your job well, and all the best for your presidentship also.
Thank
you.
Thank you.
Thank you, madam. Now let's proceed to the next the panel discussion in our Classic series, and I request Dr. Ayushi to take over for the panel.
Ma'am, and good evening, ma'am. So we begin with the third session, which is a panel discussion on life-compatible fetal anomalies. What next?
Just a second. Sadhana ma'am, आपके टाइम में केवल 15 minutes बचा है. So how much time do we have for the panel?
नहीं, आप you take. I might be leaving for a while, and then I will also join. You take around 30 minutes. No, it's okay.
Just asking because only 15 minutes are left.
No. You take 30 minutes, 30 to 35, 40 minutes.
And we would like to have you with us while we are winding up. So you please join after some time, na? We would like to have you.
Yes. I will be logging on.
Yes. Okay.
Just say
Thank you so much, madam. Thank you so much.
Thank you.
Thank you, Dr. Uma.
Thank you, madam. Thank you so much.
So we begin with the panel discussion on life-compatible fetal anomalies. What next? And I take the privilege to invite the moderators of the session. May I have the CV, please? Dr. Anju Jain ma'am and Dr. Asha Jain ma'am. Dr. Anju Jain ma'am is DGO Gold Medalist DNB, PG Diploma in Medical Law and Ethics, National Law School, Bangalore, ICMR course on Medical Genetics and Genetics Counseling, Diploma Hospital Management, Certified course in Fetal Ultrasound Program from FGI. Ma'am is Director at Jain Hospital, Varanasi. Ma'am has been Scientific Secretary and Joint Organizing Secretary in various programs and awardee of many programs and awards. Very warm welcome, ma'am, once again.
Thank you.
Dr. Asha Jain ma'am. Ma'am is MD DNB, MNMS, MBA, FICOG, FICMCH, Director SMSA Hospital Raipur, Medical Director Cancer Prevention and Relief Society, elected member Chhattisgarh Medical Council, Zonal Chair FOXY, Food, Drug and Medico-Surgical Equipment Committee, Chairman Mission Pink Health, IMA Raipur, Executive Member ICCP. Ma'am has 32 years of experience. A very warm welcome, madam. Next, I invite our experts for the session, Dr. Sarita Agrawal, Smita Devle, ma'am. Dr. Sarita Agrawal, ma'am. Ma'am is Professor and Head Obstetrics and Gynecology and Dean at All India Institute of Medical Sciences, Raipur. Ma'am has been Vice President FOXI 2015, ICOG Governing Council Member 2015 to 2017, ICOG Academic Council Member 2017, Chairperson HIV Committee FOXI 2010 to 2013. Ma'am has been awarded very prestigious awards with ongoing and approved research projects with ICMR4 and many others. Warm welcome, madam. Dr. Smita Dengle, ma'am. Ma'am is MBBS DGO DNB, MNAMS MICOG, Fellowship in Fetal Medicine, FMF certified for NT and anomaly scan and invasive procedures, faculty at Fetal and Gynae Imaging. Ma'am is Fetal Medicine Specialist at Bansal Hospital, Bhopal. Warm welcome, madam. Next, I would like to invite our panelists for the session. Dr. Rashmi Sharma, ma'am. Ma'am is MBBS Lucknow, MD Ops Gynae, DMRD, Senior Consultant at Apollo Hospital, Bilaspur, with special interest in laparoscopic and high-risk pregnancies. Warm welcome, madam. Dr. Yamini Manikar, ma'am. Ma'am is Director, Manikar Trauma and Maternity Care Center, Harda, MP. Ma'am is MBBS from GMC Bhopal and MS from MCH Jabalpur, working as private practitioner since 2005. Ma'am has served as Secretary of Narmadapuram Ops Gynae Society in 2022. Very warm welcome, madam. Dr. Sneh Prabha Chaube, ma'am. Ma'am is MBBS MD FIC MCH, Fellowship in Gynae Endoscopy and Colposcopy, Senior Gynecologist at City Hospital, Jabalpur, past President Jabalpur Ops Gynae Society in 2010. Ma'am is the winner of President Trophy Group B at 54th AICUG Hyderabad. A very warm welcome, madam. Dr. Monica Pathak, ma'am. Ma'am is consultant and director at Sai Sushrat Hospital, laparoscopic surgeon, specially trained in Ops and Gynae ultrasound, ISCCP trained colpologist, Secretary of Raipur Ops Gynae Society and Treasurer of Raipur Ops Gynae Society, member of IFS Executive Society and member of IMA Executive Body. Very warm welcome, madam. Dr. Kirti Kaura, ma'am. Ma'am is Secretary Association of Ops Gynae Society, Bhilai, and Director, Revival Medical Center. Welcome, madam. And Dr. Nidhi Mishra, ma'am. Ma'am is currently working as consultant Ops Gynae at laparoscopic surgeon and sonologist in Seva Hospital, Sagar. Ma'am has been the past president of Sagar Ops Gynae Society in 2020 to 22, MBBS from GMC Bhopal and MD from Raipur, Chhattisgarh, and awarded FICUG in 2016. Worked as assistant professor at Sagar Medical College from 2010 to 2017. A very warm welcome, madam.
Thank you.
I would like to invite Dr. Kavita Babbar, ma'am. Ma'am is MBBS MD FICUG, senior consultant and laparoscopic surgeon and infertility specialist at Apollo Hospitals with 15 years of experience in field of Ops and Gynae. A very warm welcome, ma'am. Now I hand over to the moderators for the panel discussion.
Thank you, Ayushi, for introducing us and the panelists. I hope all the panelists are on board. Yes, I'll share my screen, and me and Dr. Asha would try to make panel very interesting and with lots of input, expecting lots of input from all of you, and so that we can reach to a consensus. These are very practical problems which we as an obstetrician facing day by day, whether we are doing an ultrasound ourselves or we are getting a report with some of these anomalies being written on as a report. So since the two talks, we have been understanding lots of anomalies, prevalence being 184 per 10,000 live birth, and most of the anomalies, they are musculoskeletal system being involved are the highest among the live birth. And when we consider the stillbirth, then anomalies of the CNS ranks the highest score for anomalies. Why there is an importance of an anomaly scan? We have to correctly diagnose an anomaly, but well in time. There's no point detecting an anomaly when the fetus is already 28-30 weeks, beyond the period of termination. We try to not to miss out on an anomaly, and we have to prognosticate the couple regarding the anomalies which has been detected. We have to inform them about the available treatment options, and we have to allow them to take a decision involving a multidisciplinary approach, and we have to timely refer the patient fetus in utero to a higher center, either in utero or in the postnatal period. So coming to the cases, we will take case 1 and 2 together. So first case is 32-year Primi Gravida with the first visit at 16 weeks. She was married for 5 years, being treated for primary infertility, but this was a spontaneous conception. On scanning, the biometric corresponded to period of gestation by date. It was a single live fetus, 15 weeks, 3 days intrauterine gestation with the placenta anterior away from os, and there was a small unilateral cleft lip seen, palate intact, rest detailed scan showed no other anomaly. This is just a minute. This is the image which we can see the cleft lip. And the second case, it is second gravida para 1, 20 weeks of gestation, came for an anomaly scan, anti-scan done with first trimester screening, showed low risk for trisomy 21, 18 and 13. Husband had congenital cleft lip and palate repaired. On obstetric history, she had one female child delivered by LSCS 4 years back for CPT. Baby had congenital cleft lip and palate which was repaired. Baby is doing well. On anomaly scan in the present pregnancy, there was a unilateral cleft lip and palate diagnosed. No other anomaly detected. This is the cleft lip and palate being seen. Okay, and so this is husband, the cleft lip and palate repaired, and the baby, which is live, 4 years old girl, with a minimal scar showing a cleft lip being repaired. So coming to the questions, any one of the panelists can take the question. How will you counsel the couple in case 1?
Hello,
Am I
everyone.
on? Yeah.
Hello. Yeah.
Yeah, Dr. Rashmi.
Yeah. In the first case, at the age gestational age of 16 weeks, they have diagnosed it as a cleft lip. I will counsel the patient that look that it's unfortunate that there is a defect in the baby. But the good thing is it's a very small defect. Other things are normal. All the structures are normal. So it's only small defects, and the good thing is that we have got treatment for this. And the most of the time there is no scar after the treatment. And for further counseling, I will involve the pediatrician and the plastic surgeon also if they want to discuss with them before delivery also.
Would you like to say something else, like this is only 15 weeks of pregnancy? We have detected
Yeah, sorry. Yeah. And I would recommend her for further 18 to 20 weeks for further detailed scanning, anomaly scan. We'll just again rule out other anomalies are not there. Just to make sure only cleft lip is there and no other anomalies is there. And at the same time, I'll go for an IPT test. It will be good to go for an IPT test.
Can we have some inputs from our expert in this case regarding the counseling?
One thing that I would like to say is, whenever we come across any kind of structural abnormality, we should not go for a screening test then. Like an IPT is a screening test. So any structural abnormality found in the fetus, we need to have a diagnostic test. Diagnostic test for the aneuploidy. Be it a small structural abnormality or a major one. We need to rule out the aneuploidy part first. And we have to look for more abnormalities. One structural defect found, look for the others. And if they are singleton, one single abnormality is seen or multiple, so that you get to know, is it a syndromic one or a single structural defect that you are seeing. And based on that, you can form a probable diagnosis that is, can it be a chromosomal issue or can it be a genetic issue or a single gene defect? And then you plan your further counseling, speak to the parents, and then you plan your further move. Do you need to go for invasive testing? If you go for invasive testing, what is the test that you're going to order for, so that you get the maximum information, and then you plan out whether this pregnancy is to be continued or how the parents will take this, and they can take an informed choice about the pregnancy.
Exactly. It is actually, we have to explain each and every scenario to the parents. We are not here to make them afraid of. We have to tell them maybe this is a normal thing, but there can be a possibility that we might detect any other associated abnormality maybe later on around 18 to 20 weeks. This can be a part of syndrome also. And so if it is detected, she might have to go, or she may choose right now for an amniocentesis, or because 15 weeks is slightly earlier for an amniocentesis, it will be CVS, or we can explain them very well that these are the situations. She can opt for amniocentesis. And if she doesn't want, we can do a detailed scan at 18 to 20 weeks. And again, if it is a thorough scan with no other abnormality detected, then again a guarded choice has to be given, because there might be a possibility that this could be a part of a syndrome.
Yes.
Anything, any other input?
They will always ask for a guarantee, which
Yes,
we can never
we
give.
cannot give.
You know,
So we always have
Dr.
to
Anju?
give them the probabilities.
Yes, madam.
And the associations.
Means I would like to add that
Yes, madam, please.
That we should have a very positive attitude.
Yes, exactly.
It is our attitude that is transferred to the patient.
Yes, yes.
If I begin with a long face that, there's something wrong, then definitely they will magnify it 1,000 times. So we need to give them all the information, but we really need to be very positive about it, because what I tell my patients is that this problem is seen, but when we are asking them to go for an advanced treatment, advanced scans or a test, that, instead of saying that it can be to find out if something is wrong, we can always say it is to find out that everything is normal.
Yes.
It's just the phrasing of it. You counsel everything, but you are saying that we are getting proof that everything is normal. And that attitudinal shift from our part will help a lot of kids to be born in the world.
Yes, definitely. We are here with the positive.
Always matter.
Yes.
The words always matter, what we utter.
Taking a negative approach will land up in terminating this pregnancy without a test, which should not happen. Yeah. Madam Mandakini, madam is there with us, madam?
I think she left.
I think. So how will you counsel the couple in case two? How the two cases are different, and would the counseling different in the second case? Any of the panelists can take this.
Yeah, ma'am. I think in the second case, the father was already having a cleft lip, and the first baby was also having it. So there are more chances of something which has been passed on from the father, some problem which has been passed on from the father to the children. And the baby also, the first baby also has cerebral palsy, I think. In your case, you have just stated. So there, it is more important in this case to counsel this couple to go for a proper analysis, chromosomal analysis, like amniocentesis, etc.
This
to rule out any other structural abnormalities also associated, and also to rule out because there was T18 and T13 were normal in double marker testing. So we should go for a test in which not a screening test. We should go for a definitive diagnostic test like amniocentesis in this case, I guess.
In the second case, though we have to offer if they want to go, but she denied for it because she said that my husband had it, my child had it, and I don't want a further test. I know that it is repairable, and because both of them in the family had the repair, and they are very well doing. And so we have already talked about what investigation we will advise in case 1 and case 2. Apart from the first trimester screening and amnio and invasive testing, other tests, any other investigation would you like to advise in case 1 and 2?
Madam, we should follow her up for other structural abnormalities, since it is associated with lot of syndromes.
Yes.
So we should do her fetal echo also.
Yes.
Yeah.
Yes. Yes. In both the cases. Yes, definitely. So we have talked about role of invasive testing in case 1 and case 2. We cannot deny that invasive test has no role in both the cases because as already being said, they can be involved syndromic involvement also. And most of the cases these are the isolated findings and they don't need any further testing. But still, in the present scenario, we have to explain that these are the possibility, and if they want to go, we can always help them with the invasive test. So, do we need to involve other discipline, or we are only here to take the decision on behalf of the patient, or do the parents need to see the other discipline?
We can involve a pediatric surgeon or maxillofacial surgeon so that they can give a very frank opinion about the surgery of cleft lip and palate. And we can involve a geneticist also.
I think we should involve them because we should ask the parents to take an opinion well in time. They should visit and meet a pediatric surgeon and also a geneticist so that they have a complete information regarding the postnatal management if needed, and at what time and what is the prognosis of the postnatal management and the cost involved. Everything should be informed well before in time to the patient and the attendant. That would be the best approach. Am I right, Dr. Smita? Dr. Smita? Hello? Am I audible?
Yes. Yes, ma'am, you are.
I think she is not there. So, as cleft lip and palate incidence in India is 1.7 per 1,000 live birth. When we talk about isolated cleft lip, it is 25%. 45% when both of them are involved, and only cleft palate contributing to 30% of the cases. And when cleft lip is more common on left side, 80% of the cases being involved, and bilateral in 20% of the cases. And according to Fogg and Anderson, less than 40% of the cases of cleft lip with or without cleft palate are genetic in origin, transmitted through a male sex-linked recessive gene, and less than 20% of the isolated cleft palates are genetically determined. Two possible mode of transmission: by a single mutant gene, that is monogenic, producing large effect, or by a number of genes, polygenic inheritance, producing small effect. And common genes that are involved in the process are TGFB3, MSX1, AP2, IRF6, FGFR1. So, as an obstetrician, we should have some knowledge about the genetics also, and we should know the etiology of cleft lip and palate to counsel the patient also, being hereditary being the commonest, nutritional disturbances, physiological, emotional and traumatic stresses during development, defective vascular supply to the affected area. There can be mechanical disturbances, and sometimes some drugs can also affect the development of lips and palate, like aminopterin, cortisone, thalidomide, anti-cancer drugs. Alcohol, though not very common in our country, radiation exposure, infections, lack of inherent developmental force, maternal smoking is still not common in India. Syndromes associated with cleft lip and palate, we should be aware of those syndromes. They can be autosomal dominant, recessive, X-linked, chromosomal, non-Mendelian. List is too long, but at least once we find out a defect, we should see the literature and we should brush up our knowledge about it before counseling the patient. And this is the girl with a small cleft lip. She was counseled. She went to a pediatric surgeon also. She had a genetic counseling also. And the lady continued the pregnancy. She didn't undergo any amniocentesis. And this is the beautiful girl, now 1 year old now, and the lip being repaired. And there is hardly any scar seen. And I would tell you the second case, again, it was a girl child, and the girl had a cleft lip and palate. Lip is repaired, palate is still there, and the mother is now, the girl is now 1.5 years old. The mother is third time pregnant, and this time the pregnancy, day before yesterday only I did a scan. It is isolated cleft palate in the present pregnancy. There is no cleft lip. So there is a total hereditary genetic transmission. The third pregnancy also is having a cleft lip palate. Now coming to the case scenario 3, Dr. Asha, would you like to take this case?
Yeah. So this is a 40-year-old primi gravida, married for 15 years, 18 weeks pregnancy. She has conceived with IVF FET with a donor egg. First trimester combined screening is low risk. Again, as you remember what Dr. Aparna had shown, we don't know whether that combined screen had taken the age of the donor.
No, it was age of donor egg only. Donor egg.
Then anomaly scan showed abnormal fetal heart. 4-chamber view was normal. There was an overriding vessel with malaligned VSD. There was in the RBOT, you could see the pulmonary artery branching. 3-vessel trachea view, there was a small pulmonary artery and there was no other anomaly. So what you have seen is actually you have a malaligned septum, you have an overriding aorta, and you have a small pulmonary artery. These are the 3 findings. So may I ask, what is this? What is the diagnosis?
Madam, these are the pointers towards tetrodes phallus. Sorry, madam, I'm having cough. These are pointing towards TOF. And because it has a overriding vessel and malaligned VSD and the pulmonary artery branching and a small pulmonary artery. So these are in favor of FOT. TOF.
Pulmonary artery will always branch. That is how we identify it.
Yes.
But it is TOF.
Yes.
What happened?
I think my signal is dropping down. Is it okay? The screen is being visible?
It's gone. The screen is gone.
Screen is gone. Okay, Nilesh, can you share the PPT? I think my internet is going where it is stopping in between.
Yes, I will
Nilesh?
share.
Yeah, please share it.
Just a second.
So, while the screen is being shared, we can continue with our conversation. If it is a TOF, what is the prognosis? What do you think it is?
Madam, it is a repairable anomaly, but we have to take into account other factors and its effects on other structures like bad pulmonary vessels and other associated anomalies.
Okay.
There may be chromosomal anomalies, so we should go for amniocentesis to rule out any chromosomal anomalies.
Next slide, please.
What will you do? Sorry, he is not able to share right now. So,
no, it is being shared, Dr. Anju.
Acha, okay. Okay, let me just.
We can see the slides.
Okay, you can
Next
see.
Next slide, please. Next slide. Next, please. Here you can see that it's a very, very small. This is the aorta and the ductal arch. Next, please. Next. Next slide. Please go to the questions. So the diagnosis has already been discussed. Next slide. What will you do next?
Again, I think she should go for amniocentesis to rule out any chromosomal anomalies.
Okay. What is TOF usually associated with?
Yeah, sometimes it's Down syndrome.
Okay. Next, please. Will you refer the patient for a detailed echo? And whom will you refer the child to, and at which gestation would you refer that baby?
It's
Madam,
always
we
good.
should detailed echo, fetal echo.
Yes, we should have a detailed fetal echo by a person trained in fetal echo and with maybe a pediatric cardiologist with good experience. We will prefer.
And what age?
Ideally, we should do it at 20 to 22 weeks.
No.
Madam, but some experienced persons
Dr.
are
Nidhi,
also
would you
doing
like
at
to say,
18
add something?
Ma'am, I think after fetal echo be done after 24 weeks. Usually it is done at 28 weeks, but in this patient we can do it a little earlier.
No, why 28 week? Why to wait till that time? We can do it right away at 20 weeks.
22 to
Anomalies scan, we
24
can
is good
finish it
enough.
off.
24 is fine.
22 to 24 is good enough. And
yeah,
22.
So next, please. What investigation apart from fetal echo would you offer? Uska पैर नहीं चाटने देना. Apart from fetal echo, what would you offer the patient?
Madam, since this tetralogy is a part, it can be a part of many syndromes, we should discuss and offer invasive testing to the patient.
Okay.
And we should explain to them that it is a repairable anomaly with excellent results.
Means how many patients do you know who you tell them that the heart has 3 problems? They would like to continue if we are really factual about it. Once they know that they have a TOF and there could be evolving anomalies and the effect on the fetal circulation could get worse.
Very few patients, ma'am.
So that is where our counseling comes in.
Yes.
Doing fetal medicine means you try to save more and more babies. Singh ma'am, would you like to add something?
No, I think you are absolutely right in saying so. Sometimes in some cases, this cardiac abnormalities are very common, but hardly we ever see that we have to terminate a pregnancy because of those anomalies. Sometimes VSD and all, they are very small and they get auto-corrected after birth, after some time. So as you have very rightly said, that we need to save more than just be do injustice by terminating.
And we
I
have
would
to
just like
see
to add
that.
something over here.
Yeah.
Yes, Dr. Smita.
One thing that yes, we can do at the same sitting when we are doing the anomaly scan by 20 week itself, because it is 24 week or something. It is not going to add much more to it.
Yes.
Then when we are sitting for that counseling, definitely we have to tell them that is it a correctable one or not. Definitely TOF is a correctable thing, but then we have to give them the long-term prognosis. Then more important thing is we have to make them aware that will they be able to take all that brunt? Do they have all the finances? Do they have that much of emotional and social security and those things that they are able to take that thing that a small baby they will be able to take for surgery? Maybe if they're coming from a small place, staying at a higher center, taking all that brunt. And if they're very keen on all those things and they will be able to manage all that, yes, definitely they can go ahead with this thing. But then we have to rule out all the aneuploidy and the microdeletion which is associated with TOF. And then definitely the
One more
long-term
thing is,
prognosis.
this will be more of a negative counseling, the way you're saying it. But the government today has taken care that there are very many centers where babies are being operated. So, so it is not so much of a cash crunch. It's not so
all
much
the
of a
places,
cash
see,
crunch.
Raipur, definitely Chhattisgarh, they're doing, I'm aware. But is the family ready for all those things? That also they should be knowing, because many
that is
times they
that
take a
I
step.
agree that it is ultimately the family that has to take care.
Yes.
So again, what I would say is that it's the way you say it. That
definitely,
these
but
are
they
the
have to be brought.
facilities that are available.
Awareness has to be there. Awareness has to be there that these are the things. Are they ready for it? If they are ready, we don't have a problem, because many a times decisions are taken in an emotional way, or maybe they just want a baby in hand. But later on, when they go through all this, they say, we never thought about all these problems. So it's better that they meet the pediatric cardiologist also, the cardiac surgeon also. They get to know the way ahead.
That
and
is
they
part
move.
of the counseling, that once you have
Yes, that's what I'm
diagnosed,
saying.
they would have to go and meet a pediatric surgeon. They would also
Yes.
have to go and meet a cardiologist. But ultimately, the decision is always the parents. But we as fetal medicine people have a great chance if we are aware that these are the venues where treatment can be done, where there will be very little charge, and they are willing to, bring that child into the world. That is, I think, should be more of our focus.
And I would like to add, we have to see the history. This is an IVF pregnancy, that too with the donor egg. So the mother is already she has no chance of having her own baby. And so we have to discuss with it. This is the problem. They might be very keen for this pregnancy. So if we have an opinion in advance in utero by a pediatric cardiothoracic surgeon and a pediatric cardiologist, they do so many scoring and they tell them the prognosis, and they can tell them what are the chances, because TOF has an excellent chance of correction if it is an isolated TOF. So all our efforts should be to rule out other structural anomalies, any associated problem with and any medical disorder like diabetes has to be ruled out. Pregnancy has to be very well taken care of, and delivery should be planned at a higher center with all facilities for the neonatal management. And this has to be explained to the patient.
We transfer the baby in utero.
Yes.
That is what we transfer the baby in utero. So next, please. Is there a role of invasive testing? I think we've discussed it. Next, please. Yeah. So this is for all gynecologists. Will you advise MTP?
If the problem is correctable, then we should not, I think we should not advise MTP. We can counsel the patient. It is not on us to advise MTP. It is the patient's discussion whether she wants to continue the pregnancy or not. We can just tell them about the anomaly and tell them that it is correctable. So baby is, it is not a life-threatening anomaly. So the baby is able to survive if we correct this anomaly. So we should not advise MTP to this patient.
Sneh, ma'am.
Yes, we will not advise MTP because we have discussed so many things, and still it is an IVF conception, and there are many ways to go. So I will not advise MTP and explain everything and then let them take decision.
Dr. Rashmi?
Yeah, continue.
Yeah. So your opinion on this, will you advise MTP?
No, we'll continue the pregnancy.
Yes.
No, we cannot say you continue the pregnancy, nor we can advise MTP. We have to give this decision. We have to leave this decision to the parents. If parents say, no, we don't want this pregnancy, then you cannot say that you have to continue. So it has to be their choice.
The question is, will you advise?
नहीं मैडम, अभी
the
मरीज
answer is unanimously we will not advise him.
नहीं, मरीज आपसे पूछेगा डॉक्टर साहब आप बताइए क्या करना है, तो ऐसे में आपने नहीं बताना है क्या करना है, हमें नहीं बताना है क्या करना है, हमें ये बताना है ये पॉसिबिलिटी है, ये सर्वाइवल बहुत अच्छा होगा, लेकिन हमें मरीज का गार्जियन नहीं बनना है. दे हैव टू टेक अ डिसीजन.
पर वो लास्ट में तो वही बोलता है, मैडम आप बताओ क्या करोगे.
नहीं, आपने नहीं बताना है. आज के टाइम में नहीं बताना है.
Responsibility of decision making.
Yes.
Next, please.
So this is a very complex situation. We have to handle it very delicately. उस handling में don't become the decision maker for the parents. Please. Refrain from becoming a decision maker, because God forbid if something happens to the child after surgery, they can blame you for anything. So on paper also you have to write it is Counseling done, patient referred to a higher center, pediatric cardiothoracic surgeon, pediatric cardiologist, and all scenarios, prognosis explained to the parents and decision left to the parents whether they want to continue or not.
Come on. So we go next slide. We've already been at this for more than half an hour.
Yes.
So this has been discussed. Next, please. What is the genetic predisposition in this case? What is Fallow's connected with? Trisomy, TOF. What is TOF connected with? Next, please. This has already been taken by Dr. Anju. Can we prognosticate by antenatal USG? Is it possible to prognosticate by an antenatal USG?
Yes.
Dr. Sita?
A good fetal echo can tell how much severe is the pulmonary stenosis, how much is the severity is pulmonary stenosis is severe or not. So a good cardiologist, a good pediatric cardiologist can tell the prognosis of the fetus. So it's
And there
always
is one more thing, that the disease evolves with time, with function. As the heart grows bigger, the baby grows bigger, the demands increase. So there has to be a close follow-up.
Yes.
There has to be a very close follow-up. So what we say today may not be the complete truth tomorrow. And this has to be counseled in the very beginning. So next, please. So this is the most common cyanotic heart disease, but there is also a pink TOF where the babies do not get cyanosed. And then the cause is unknown, but 17% only are associated with chromosomal anomalies. And the clinical manifestation depends upon the severity of disease and its association with chromosomal and other anomalies. Antenatal diagnosis is important to plan early treatment after birth. Prenatal findings suggestive of TOF, large aortic root, small pulmonary artery, or stenosis of the right ventricular outflow tract, outlet VSD, and an overriding aorta. Pulmonary outflow obstruction may evolve during pregnancy, and prognostic factors are the presence of extracardiac anomalies, severe pulmonary artery stenosis, absent pulmonary valves. It is easily correctable heart defect with excellent survival and good quality of life. Both of them are very important. The quality of life is also very good. Next, please. Anju, you are taking this?
You continue, you can see.
Okay. So this is a 24-year-old primi gravida married for a year, spontaneous conception. Now, first visit is at 12 weeks. NT scan is normal. First trimester combined screening shows low risk for trisomy 21, 18, and 13. Anomaly scan at 18 weeks shows an aberrant right subclavian artery or an ARSA. Now the counseling was done. The couple opted for NIPT, which again showed a low risk. So they were still not satisfied. And they went ahead for amniocentesis, and it was again normal. Next, please. So this is an ARSA, which you can see in the 3-vessel trachea view. This is the aberrant right subclavian artery that's going behind the trachea. Next, please. What is ARSA and why is it important to look for it? Aberrant right subclavian artery. What is it and why is it important to look for it?
Ma'am, ARSA is aberrant right subclavian artery. Normally, it arises from innominate artery, but when it arises from aorta, it is called aberrant and it courses behind the trachea. So, and it is a marker for many genetic syndrome. That is why it is important.
Next, please. Can it be a normal finding?
Madam, in 1.4% of the cases, it can be a normal finding.
Yes, so that percentage is really low. It's
Yeah.
only 1.4%. Next, please. Does she need a repeat scan? And if yes, why? If no, why? She is 18 weeks. Okay. Do you want to do a detailed echo?
Yes, madam, since it is associated with many genetic syndromes and CHD, we should do a detailed echo examination to see further structural abnormalities.
Next, please. How will you counsel this patient?
Madam, we will explain about the findings and its association with the other genetic syndromes and cardiac anomalies in particular. And we will also explain in a way that they should not be, take it in a very anxiety, just to create anxiety. And we will explain that you need certain further follow-up tests, and it is on the couple's wish to undergo such tests.
Next, please. Now, if they agree, what will you suggest? An NIPT or an amniocentesis?
Ma'am, NIPT is just a screening test, whereas amniocentesis is a diagnostic test. And since ARSA is associated with many microdeletions, and also we should go for invasive testing.
Okay, next, please. Does the couple need referral to pediatric cardiologist immediately or later?
After fetal echo, she should.
After fetal echo, yeah.
So after you have actually done a very detailed fetal evaluation to rule out that there's nothing else absolutely, or if there is something, and done a fetal echo, then you send to the cardiologist. Next, please. Is any follow-up required postnatally?
Yes, madam, detailed evaluation of the newborn should be done by a pediatric cardiologist because a direct examination is always helpful, and it should be correlated with the findings in the echo in antenatal period.
Next, please.
Actually, ARSA, we need to understand it is a soft marker, which is a high likelihood ratio of association with trisomy 21. So, but now it has been dropped from the soft marker list because it is a common normal finding also, with so many studies being proven that. So we need to rule out trisomy 21 if we find out ARSA. That's what being done with the NIPT and amniocentesis. And a detailed echo, if it is everything is normal, we can very well reassure the parents that this fetus is going to do well, and definitely after delivery, this baby can be seen by a pediatric cardiologist. And exactly this happened. This lady delivered a healthy female child by cesarean at 37 weeks, and the baby was seen by pediatric cardiologist. ARSA was seen postnatally also, but it has a very good prognosis. It is a normal variation. So it is not associated with any disease. So once we know the concept, then only we can counsel the parents. So just telling a soft marker, identifying it and raising alarm, false alarm, when we have ruled out the problem would be bad. So we should know what investigation we should do, and once we have ruled out that, we can very well reassure the parents.
Next, please.
Coming to case 5, it is second gravida para 1 with first full-term normal delivery female baby which is alive and healthy. Presently, she was 22 weeks pregnant, came for an anomaly scan which revealed a single live intrauterine pregnancy with the placenta posteriorly located in the normal amniotic fluid On an anatomic survey, there was a bilateral dilated renal pelvis noted with an APD of 5.2 millimeter and left side it was 5.5 and no other anomaly detected. Next slide. So, how significant is this renal pelvis dilatation? We just listened from the madam.
Madam, at 22 weeks, this is significant.
What else wants me to tell you in a scan which was missed? I have not told you. What else would you like to see?
Madam, once we are doing the scan and if we find findings, because it will depend on a lot of factors like maternal hydration or state of bladder emptying. So we should wait and we should again confirm the findings. And if it is persistently at this level, then we must follow her up.
So we need to see the bladder. We should comment upon the bladder, whether it is full bladder or it is a partial bladder, and we can make the patient walk around, wait for half an hour, and we have to reassess to confirm whether there is an actual renal pelvis dilatation or it is not there.
Yes.
Next, please. So what are the association with any aneuploidy and a syndrome with the renal pelvis dilatation?
Madam,
Again, it is a soft marker.
It is a soft marker with very less likelihood ratio. But we must follow her up, and if results of FTA first trimester screening is available, then it practically rules out. But if we don't have first trimester screening results, then I think we should follow her up and then decide.
Can we offer her something like if she has come for 22 weeks for the first time, she's not done her FTA screening and she's not done her quadruple marker also, would you like to tell her that let's go for something else?
An IPT we can
NIPT can be done, madam, because
Yes.
invasive act is not will be indicated.
How do we follow up this pregnancy?
Madam, we do serial growth scans. We see whether the diameter is increasing, and we have to assess the whole uro system of the baby, like condition of kidney, calyceal dilatation, or the condition of the ureter, so that we know that it is only confined to the pelvis or it is affecting the kidneys, whether it is unilateral or bilateral affection.
Basically, it comes under luto, but we have to look for, Dr. Smita, if I am wrong, please correct me. We have to look for other soft markers. If we have found out one soft marker, we have to definitely look for it, search for other soft markers, do a detailed scan so that we are not missing out on any other anomaly, any soft marker which can point on towards trisomy 21. And then definitely we are following up with the renal pelvis dilatation. And in these cases, if though we are not supposed to look for the sex of the fetus, but if it's a male fetus, we have to look for posterior. It can be posterior urethral valves also, resulting in a pelvic backflow changes and a dilatation. Dr. Smita, your comments?
Yes, it is always a dictum, as you said, Dr. Anju, that whenever we find one soft marker, look for others. If we find one anomaly, look for other. So maybe you're halfway through your scan and you find something, you repeat all the things and look for or search more diligently. So look for other soft markers and then reassess or recalculate your risk for aneuploidies. And then definitely, yes, if you're finding a renal pelvic dilatation, I would again move my probe down, look for the sex of the baby, because then more of association with male genitalia, that am I looking at a posterior urethral valve? Can it be there? I look for the whole urinary system. I look for the kidney structure. How is the corticomedullary junction? Is the differentiation maintained or not? So my perspective changes. Whenever I find any kind of a soft marker or any abnormality with any system, I will go more deep into that system and look deeper and try to find out more things out of it. So you're right, Dr. Anju.
Thank you. So next, please, Nilesh. So is there any I would like to have other panelists also participating. Dr. Sneh has been wonderful panelist, and I'm really happy to hear everything from here. So, role of invasive testing. Is there any role of invasive testing in isolated renal pelvis dilatation?
No, we heard from Sadhana Gupta ma'am.
If everything else has been ruled out, yes, but trisomy 21, if it is an very 5.2 is just borderline. If it is very obvious, then there might be we can offer our amniocentesis. Dr. Smita, what do you say?
Yeah, if it is an isolated one and a borderline one, then definitely you can offer
No.
a screening one.
Yes.
If a first trimester screening has been done, then we are into a very safe zone.
Yes.
We can just follow it up. But yes, definitely, if nothing has been done, then we do offer at least a screening test once your other things are ruled out. But two or more markers along with this RPD, if I'm finding one more marker, then definitely I would go for an invasive one. But
Definitely.
alone isolated one, I might opt for a screening one.
Sure. Next question. So, any comment on postnatal advice? Because parents will ask कि अभी आगे क्या करना है, how the baby will behave, and what is the follow-up of this baby? Yes.
Yes, we need to do follow-up of the babies because many times other renal problems are seen in such cases. And usually we inform our pediatrician, they do the follow-up very nicely in such patients because they need to have like how much is their urine output is okay or not, how much they see the further dilatation of the pelvis in subsequent scan also. Postnatally also they do the scanning, do the follow-up, regular follow-up.
So we have to explain them that they have to have a postnatal one follow-up at least is needed. If a baby is passing urine well, the pelvis dilatation is not increasing, then this baby can be very easily followed up. But this has to be documented. Next, please. Dr. Ayushi, so this is just renal pelvis size should not exceed 4 millimeter before 32 weeks and onwards from 30. I think something is missing, and 5 millimeter after 33 weeks, and its dilatation is observed in 1 to 5% of the pregnancy, and in 30 to 50% of those pregnancy, urinary abnormalities were confirmed postnatally. So, factor affecting renal pelvis diameter are maternal hydration, grade of fetal bladder distension, recent emptying of bladder, check for calyceal dilatation, which would be indicative of obstructive lesion and needs a postnatal evaluation. Next, please. I think, do we have a time or should we stop, Ayushi?
7:30.
7:30. So, ma'am has joined us?
No, ma'am is not there.
Ma'am is not there with us right now. Ma'am, I'm contacting with her if she can join.
Yeah, because it is already 7:30. So I think this is the last case. Should we continue or should we stop? Choice is yours.
I think
should we wind up? We'll just take 2 minutes for this case. This is a 34 weeks pregnancy. Primary gravida came very late at around 34 weeks for growth scan. It was a single live fetus, biometry corresponding well. But on abdominal transverse view, double bubble sign was seen. Scanned and in 20 weeks showed a normal scan with no obvious anomaly. Okay, next please. Next slide please. So, how can you comment upon the above case? Anyone can take up this case, or Dr. Smita, you can hurriedly take up this now and comment upon this.
Double bubble sign. Whenever I think the first thing that I would see is first trimester screening done. What was her trisomy status? That's the first thing that clicks me up. If that aneuploidy is clear, then if I'm clear on that part, trisomy cannot be there or the risk is very low, then I think of structural things as well. So I look for the other. It can be annular pancreas or maybe some duodenal or jejunal obstruction that might be the reason for this double bubble sign. So as I said, one problem if I see, I do my rescanning again. and try to look for other structural things. And then I sit with the parents and then try to counsel them regarding all the things, the possibilities which can be there.
But since he's already 34 weeks at this gestation, how can we counsel and how would we help his parents? Because already baby is viable and is going to deliver.
Yes, definitely. So they need to meet a pediatric surgeon. Their aneuploidy, I hope their aneuploidy is all cleared off.
It is not done. It is not done. She's come to us for
Not
the
at all
first time.
done.
Yes, yes.
So even at this stage, then I can say I will offer them because they have a right to know it antenatally. And
Okay.
then now I have the choice that if I have a proven T21 report or any other kind of aneuploidy report, I can always ask the bench for a permission. So that one point is there, though quite a controversial thing or something for
No, it is
discussion.
very
But yes, I
controversial
will
because
offer
34,
that's what I
34
said,
weeks,
very
it is
controversial and
like
open for
viable
discussion.
baby, na? So
Yes.
just putting the parents into a psychological so much of trauma. I think we can offer them in utero transfer to a higher center, so they have a good antenatal care and a best delivery possible way.
We'll always
We should try to
discuss.
deliver her normally, normal vaginal delivery, unless there is an indication for cesarean, and postnatally
And
we
they
can
will
evaluate the baby.
definitely they have to meet a pediatric surgeon as well, because
Yes.
recently I had such a case and we
Yes.
did an amnio. It came as normal, and that was annular pancreas which was causing it. So
Okay.
immediate after delivery, the baby was evaluated and later on posted for surgery and everything.
Yes, yes.
So they need to know the possible diagnosis, and the pediatric surgeon will definitely give them an insight, and then they can go ahead at little piece. Okay, they have further ways out for their baby.
Similarly, I had a case that baby had a double bubble sign, diagnosed at 34 weeks, and the father was very much insisting on a normal vaginal delivery, which I had also planned, but the lady landed up in CPD. So, and there was a thick meconium also in second stage. So I explained them we cannot deliver her vaginally. He said, no, my baby will be abnormal. I don't want a vaginal cesarean. So I said this mother will end up in a rupture. So we did a cesarean. It was a 3.9 kg female child, immediately referred to a pediatric surgeon, and the surgery was conducted. This baby girl is now 4-year-old, perfectly doing fine.
So I mean, things do come out well. They do
Yes.
come out well. Yeah.
Yes, yes. So I think we can wind up here, and I hand over. Thank you so much, panelists, for a wonderful discussion. Though I couldn't see a few of our panelists like Dr. Pathak, and I think they were not there on the they didn't join. So thank you so much. I now hand over to Ayushi for further proceedings.
Thank you, ma'am. So we have come to the end of this very informative and practical panel discussion. I would like to thank the societies of Raipur, Bilaspur, Bhilai, Katni, Jabalpur, Hoshangabad, and Sagar for coming together for today's webinar. I would like to thank our chief guest, Dr. Abha Singh ma'am, for her gracious presence and words of wisdom. My sincere gratitude to our guest of honors, Dr. Mandagini Pradhan ma'am and Dr. Kavita N. Singh ma'am, for the words of motivation and blessings. Next, I would like to thank the presidents, secretaries, and seniors of the societies, Dr. Manik Pansis madam, Dr. Shruti Malvi ma'am, Dr. Manoj Chelani sir, Dr. Jagriti Nagar madam, Dr. Vandana Gupta ma'am, Dr. Tabassum Dalal ma'am, Dr. S. Bethare sir, and Dr. Uma Nigam ma'am for chairing the session and giving their valuable inputs. Regards and congratulations to our wonderful speakers, Dr. Sadhana Gupta ma'am, the key organizer of the program, for the marvelous talk, Dr. Aparna K. Sharma ma'am, for the excellent and very informative presentation. I would like to extend my heartfelt gratitude to the moderators of the panel, Dr. Anju Jain ma'am and Dr. Asha Jain ma'am, for planning such wonderful case situations for the panel discussion. And thank you, our experts, Dr. Smita Dengle ma'am, for the useful tips and expert opinion, and Dr. Sarita Agrawal ma'am, although the ma'am could not make up because of some emergency situation. Next, I would like to thank our esteemed panelists, Dr. Rashmi Sharma ma'am, Dr. Yamini Manikar ma'am, Dr. Sneh Chaube ma'am, Dr. Kirti Kaura ma'am, Dr. Nidhi Mishra ma'am, Dr. Kavita Babar ma'am, and Dr. Monica Pathak ma'am for giving their valuable insights and engaging discussion. Once again, a lot of thanks to Dr. Anju Jain ma'am and Dr. Asha Jain ma'am for all the hard work for the program. Thank you, IT team, for the excellent platform and the audience for the patient listening. Over to the Anju Jain ma'am for the last words.
Thank you so much for our lovely audience, and special thanks to Dr. Asha and Dr. Smita for giving so wonderful inputs, helping me out in this panel. And thank you so much, and thank you, my dear audience. And with the last words, I would request all the societies, secretary, president, and the members of the societies, kindly do come up for voting. Do cast your vote, and definitely in favor of Dr. Sadhana Gupta, because your small vote, single vote will bring a change. And for bringing a change, we have to come out of our house. We have to vote. Voting should not land between 40 to 50%. It should reach 70 to 80%. And to make a leader win, to bring a change in our work society, to make Dr. Sadhana Gupta win, so that we have a word, we have a saying. Please do vote, and if possible, all the secretary and presidents do have a physical CME between 1st to 4th of August, so that maximum people, they attend it, and you can ask them to vote. Because most of the time, हम अपने इतना busy हो जाते हैं, हम vote ही नहीं करते, सोचते हैं इतना इम्पोर्टेंट ही नहीं है वोट करना, लेकिन आज के टाइम में चाहे देश के लिए वोट करना, वो भी बहुत इम्पोर्टेंट है। 2024 में भी हमें सबको जाके वोट करना है मोदी जी के लिए। थैंक यू सो मच।
Thank you, Dr. Anju. It was an excellent panel, and the whole CME has been really great. The topics were also of very practical importance, and it was an evening well spent. Congratulations to all the speakers and the panelists and the moderators.
Thank you. Dr. Asha, should we call off this day?
Looks like she's busy.
I know, actually उनका morning was, वो बारिश इतनी हो रही है वहाँ पे, that's why.
Even here.
Yes. So Ayushi, and thank you Corona people for making this webinar happen so well, conducted so well. Thank you Nilesh ji, हमारा बीच में network खराब हुआ, you very well managed it, screen share. Thank you so much. Looking forward again. Thank you.
Thank you, madam. Thank you from all of us. Thank you. It was a
I'm
very
ending
nice
the
panel
session.
and very nice case scenarios, madam.
Thank you. Okay.
Thank you.
Bye.
Thank you,
Bye.
madam. Bye.